Can I give you all a 1 minute warning so you can get sat down? Morning, Kate. Good morning, colleagues. It's 10 o'clock, and I think you know we start with some informal feedback from a series of visits that we've done. Okay, it's a bit hit and miss, isn't it? Throughout the hospital today. There were a lot of groups doing visits. There were 8 groups. So you've got basically 3 minutes each. I'm going to have to be really strict. Oh, sorry, James. Andrew stole your place. Without further ado, I'm going to start with James Marsh's group. And who's speaking back, James? Jenny, over to you.
Thank you very much. I'll try and set the 3-minute challenge. We went to see the women's area, which was very appropriate on the International Day of the Midwife. As James very politically mentioned on a number of occasions, and it was warmly received. I would say the overall tone of the visit was one of professionalism, friendliness, and staff that didn't appear completely stressed. The area was not busy, and wasn't busy at the beginning nor at the end. It is a disadvantage of the time that we do these visits, but also I think a reflection that perhaps we made was that staff often comment on the extremely busy times, but there are often times when there's quite a lot of capacity within the system. The 2 areas I'd like to mention specifically clustered around estates and staffing, and then just a couple of comments about the impact of group working. The familiar estates issues, a poor lift that breaks down, mildew, and a host of normal estates running matters. The frustration being that formerly they had somebody dedicated to the area that promptly resolved issues. Now, with a centralised system, there's a very poor responsiveness, and things such as doors not on their hinges can go on for days, if not weeks. The impact of the change of the way we deliver services with cluttered but clean corridors and the lack of we found recurrent everywhere. And then the final estates issue was really the lack of waiting areas, that because we've got so much kit, it means that there aren't often the places patients need to wait. Or in the most acute situation, the fetal medicine unit, which is where often very bad news is given to patients. They are seen in a room and they exit that room, often in distress, straight into a routine antenatal clinic with midwives, and that must be difficult, and they wouldn't want to run the service like that, but that's the way the estates do it. I've mentioned the staffing. Despite the fact that the number of deliveries have fallen, they all had requests for more individuals and no acknowledgement that that had to come from somewhere, so there was a mismatch there. They were aware of all the reviews and things that had happened in midwifery, and the Ockenden impacts. One was they'd suspended the home delivery service. And then the final comments were around group working. We did go also to the neonatal unit, which again is up to 18 cots and at the moment has 8 babies. There was active talk there about improving flow between the different units and better rationalisation of resources and more to be gained. And the final comment is there has been dialogue between St George's and the other sites in relation to the findings of the midwifery report, and they have actively addressed similar issues to staffing rotas and triage processes. Thank you.
Thank you very much indeed, Jenny. I won't encourage any of the others as we've got a lot to get through, but I think that was very clear, and I think there will be some consistent themes. So the next on my list is Phil with, I think in the end you're on your own, were you, Phil?
Yeah, I marched off on my own, which was great. So I went to in fact radiology. Was welcomed there, very good reception, lovely reception team. Were dressing up their reception area ready for the coronation, so that was a happy start. And met Joe, who's been with the trust 23 years in radiology, very enthusiastic, and we had a really I had a really interesting visit. I'll just put out a few things, Gillian, because I could probably talk about it for some time actually. We started talking about staffing, and this week they've been short-staffed, but they rearrange rotas, so there's a constant rearrangement. They get up to sort of rearrangement number 9 or 10 each week as they make sure that they can cover the slots. That they're moving from a 5-day rota to a 6-day rota, and then potentially a 7-day rota. That's about to kick in. That's been quite stressful, but it's been treated as a thing that needs to change, and they're working through that. And I was shown the new rota and how it's all going to work and improve things. So good. Facilities, I would describe it as some heavier, some good, some bad. There's some new bits of kit and some new areas in radiology, and there's some very old bits which have been there for sort of 20-something years. So you know, there's some stuff they would like it improved, but there's from a flow perspective, actually, they were all saying it works quite well. Got into some of the sort of more interesting areas, sort of more detailed areas. IT was interesting, so I think it's called PACS, but we've got a new PACS thing coming where we're going to connect with South West London, which is everyone's very excited about, where we'll be able to see scans and things done in different hospitals in South West London. They'll be able to transfer them from hospital, and that's coming in about 3 months' time. The IT team, a little team of 3 in the corner, were working on that, and it's all going to be in the cloud as well. So that's again. Then we went on to see AI. There's a piece of AI called, in fact, Annalisa, which is there to work on chest scans at this stage, and it's the moment it's picking up if there is a chance of in fact cancer on, and it does it in less than a minute. So there's some really interesting stuff going on within that unit, and all being worked on enthusiastically. They obviously they said they would like newer computers and more kit, and it has to be rebooted, but the general sense was that it was that's all going in a good direction. Saw MRI area where there's 2 machines inside and there's some outside, all very calm. All the colleagues I met said it was a good team to work on, all enjoyed working there. One was a bank radiographer who used to work here but now has come back with bank. He left for all good reasons, but then, because he is now putting some time back in, he really enjoys coming back here as a bank member of staff. And so generally a happy team, I would say. It's very busy, and again, so it is busy, I think all the time probably, and there's just constant flow of patients which come in, some from A&E, some are planned, some from the theatre. So it was explained to me that they come from all sorts of different places. Some have more priority than others. Most waits are less than an hour and a half at the moment. So generally it was uplifting and really pleasing to see. Thank you.
That's lovely. Thank you very much indeed, Phil. So next on my list is James Blythe, and Yin went to the dentist, I think.
Oh, sorry.
Am I right? Yes. Who's feeding back? Is it you, Yin?
I don't mind doing it. But just to say that Derek was in our group as well.
I'm so sorry, Derek, you're not on my. I was going to ask you on something else.
So we went to what we thought was the dental pod, and we ended up going to the maxillofacial department as well as plastics, and it was very interesting to be there. We spoke to a number of people. So in terms of top lines, they see about 15 sort of patients a day. My mic. Yeah. 15 patients a day, and in terms of the key issues, one of the things that they were quite keen to have was a sort of a waiting area for children particularly those who are disabled, to be able to have a space for themselves without being in the main sort of waiting area. And when we spoke to Evelina, who's the sister, she became a sister about a couple of years ago, I think, and she had been there for about 12 years before. And for her, one of the key issues was about managing staff and sort of having the conversations with staff. And when James asked her about whether she had enough support in terms of transitioning to her new role, she was very, very complimentary about her matron, and thought that it was wonderful to have that sort of level of support. So that's, I'm just going to stop there and ask Derek and James if they've got anything else to add.
Yeah, I think a few things came out. Staff morale I thought was very good. People were happy that there was a happy team. That was really good. Evelina was really a model of enthusiasm and good care. She applauded the input of her senior, who I think was Heidi. So shout out for Heidi, who'd really been very instrumental in her taking on the role. I think don't worry,
They're not working very well today, are they?
I'll shout. The estates are really tight, and they've got 4 procedure rooms clustered into what I would call a couple of cupboards, really. It's really tight. If you had a crash in there, it would be very difficult to get the crash trolley in. I mean, I did check, they knew exactly where the crash trolleys were, and they were up to date and everything. It always was all spotlessly clean, but you've still got the problems with peeling paint and problems with ventilation. They have to keep the windows open to get it properly ventilated. So the recurring issue of, we know our estate is a problem. They're making the most of what they can within the limited estate. But this issue with the children waiting in the main waiting area, which is very tight, and I think she's particularly keen on children on mental health issues, or who found it hard to cope with the anxiety of being in a waiting room for a dental procedure when they didn't know what was happening, and they were just packed in with everyone else and just trying to have a separate space for families. And that was really what made, and James came up with some possible solutions for that without hitting the budget too hard. But yeah, just wanted to flag up the estates worried me. But the morale was very good, and the management structure was I think very positively reported.
So a big thank you to Derek and Yin, because 2 of you managed to keep to time, so thank you, and really interesting to hear. Again, some very common themes. So Thurza, you're next on my list, and I thought you were with Derek, but that didn't happen, did it not? Okay, so right, okay, so that explains why Derek went to Dental and MaxVax. So next on my list is my own group, which was Stephen, Peter and me, and I think Peter's going to
I am,
feedback.
thanks, Gillian. We went to the renal dialysis unit, which is just to the left as you come in through the main entrance. We managed to locate it. That was good, and it's actually in a relatively modern state. It felt in a good condition as you went in. It gave a sense of good order. As we got into the main ward area, it's busy and quite crowded, quite cramped. It has capacity for about 28 patients, of which 27 were in there today, just 1 no-show, so it was absolutely at full capacity. As Gillian mentioned, it's quite warm in there, just partly because that's actually the process of dialysing. It cools the blood, and so they have to have the temperature up, which is something we learned today. It's split between roughly 3 new starters, and the rest are kind of chronic patients who've often been in there for some time. One of the patients I spoke to had been in for 5 years and was still like to be ongoing for some considerable time. And I think similarly for yours, Gillian, I think was a long stayer. So overall, there was a sense of good order. We'd missed the peak busy time, which is essentially 3 dialysis shifts from 7:30 for 4 hours, and subsequently 2 more shifts. So if we'd been in there at 7:30, I don't think we would have been welcomed. But by the time we got in there, things were well set up, and there was a chance for them to talk to us. Very positive feedback from the staff. They were happy. There was a sense of good teamwork, of respect. And I think one compared that to a previous trust that she'd worked at was definitely felt quite different from that. So I think that was all good news. The 3 or 4 issues I'd just like to flag, or we would like to flag, I think, that kind of emerged. Initially, they didn't seem to have too many issues they wanted to flag, but as time went on, as they become a bit more accustomed to being with us, they were a bit more open, I think, about their concerns. So number one, they said for them, was transport. And the problem that creates in terms of patients not being picked up on time or dropped off on time, and the backup that creates. And it can mean in some cases that patients consequently don't get the full dialysis time that they should have had, which is presumably to their detriment. So they were very clear that was their number one concern. The second area is about behaviour issues, and this is about patients to staff. And there was about 5 or 6 patients who were particularly difficult and they thought had mental health issues. They do call in security to assist, but they didn't feel that was sufficient backup from security to the extent that was needed to get the message across about what was appropriate and inappropriate behaviour. So second issue was behaviour. The third was just around staffing. When all are there and post-COVID and there's no sickness, there's about 8 nurses, 3 HCAs, I think matron probably on top. That works well. If they're short, they said that then puts on some additional pressure. And the fourth point was around the issues that the fact they are full to capacity, which can mean that patients can't be moved off the wards into the dialysis unit, which consequently has that backup effect of not freeing up beds. And that's partly because I think there's no room in the satellites to move people from the dialysis unit into that, which is how the process works. So kind of, again, it's trying to work out how to collaborate, work with the satellites to work backwards to freeing up capacity, and that will help back to the wards in due course. So I think those were the 3 or 4 issues to flag, but overall it was, again, a positive experience. Thank you.
Thank you, Peter. That was a great summary. I'll take Chair's prerogative, and we're doing so well on time. I'm just going to say I had a chat, quite a long chat with a patient who's got a lot of experience working with us, and had also had a transplant at George's actually, which had been successful for a period of time. And she spoke really warmly about the staff and the support and kindness that they gave to patients. And I had a brief conversation with a youngish man actually, and he reinforced exactly the same things. So that was very good to hear. And then I spoke to the partner of a patient as well, who was a very complex patient, but the partner was very complimentary about our staff and their care and attention to patients. So that was all very good to hear, but in no way dilutes the points that Peter made. So the next on my list is Arlene. Who's reporting back, Arlene? Martin, is that okay? I love the way Arlene's got into delegation big time here.
I'm very happy to do it, not
Thank
least
you.
because actually it's a very positive story. We went to endoscopy. Sorry, I had trouble saying that word. And also to the eye surgery. And in both cases, they had enough staff. They didn't say there were any problems. They seemed quite happy. The environment within the limitations of our estate was very impressive. In fact, one of the refurbished areas looked really good, and they said that patients often comment on how good it is and particularly how clean it is. So everything seemed to be very well organised. I don't think actually, given that we probably need the full amount of time, but I will use it just to focus on one issue because I think it's of wider interest. The last Epsom and St Helier visit of this sort that I did happened to be the Arlene again, and we went to haematology. And there's some similarities, I'm oversimplifying it, but roughly they are Monday to Friday days. In haematology, there was an issue, couldn't get enough staff, because particularly nurses, because they had to work 5 days a week. And they've been trying for some time to get a basic sort of shift system in so that they could work extended hours over fewer days. So when it makes more sense is when you hear that. So when we asked the nurses in these units, the way that they work is the hours that the clinic is open is too long to do 5 days a week full time, if you see what I mean. So what they do is they do 3 long days a week, which means that then obviously they have more time off, which of course increasingly that's what people want to work. And because of that, they found it very easy to get people to work there. So I'll stop there. See if anybody else
Well, a
has got
lesson
anything.
for our times, I think, Martin, you might say, mightn't you?
Yes, and you know, hopefully it's good evidence of the need for more better approach to flexible working. Although in this case, it's not that they're working fewer hours; it's just the way that they're working the hours makes much more sense for them. Thank you.
Great, and then ultimately for our patients. Thank you for that, Martin. So next on my list is Chris and Paul. Am I right? Chris, are you going to feedback? And you went to pharmacy, according to my list.
Your list was quite accurate. So Paul and I were challenged when we arrived because we weren't wearing coronation colours. But I did try and bluff my way through saying that purple is a mixture of blue and red, but which allowed us entry. So we had, I thought, a very worthwhile and good meeting with and talked to several of the staff there. There are 4 departments to pharmacy, which was sort of news to me. There's what I called storage, which is the pharmacy articles coming in and being stored and being checked that the right amount has arrived and so on. There's a cancer section where they deal specifically with cancer treatments and some other special biological type treatments. Outpatient section and the inpatient section. We visited all of those. The things that stand out for me is how cramped everything was. It was clean, but there's just no room, barely any room to move about. And as we were there, we were forever having to step aside to allow someone through. So just sheer physical space is a major issue for them. One of the early things that we picked out is they've moved to a 7-day rota, and that I suppose picking up a little bit about what Martin has said, that has, though it appeals to some, it equally doesn't appeal to other members of staff, and it's been quite complicated to initiate that and get it working smoothly, and indeed it's not entirely working smoothly. Now, whether it's working as well as it can, I don't know, but certainly I think would merit some looking at and some support potentially for them. Most of the areas we talked to were well staffed, but they do have an issue with recruitment, particularly at a lower level, level 2. And retention. Part of that problem is that there are increasing numbers of pharmacy type jobs available in the community, particularly in general practice. And these jobs are quite attractive because they're attractive hours and flexible working and so on and so forth. So they do have an issue with retention. I talked about their training. They're very keen and get their statutory training done. But the member of staff I talked to did feel that they don't necessarily have the time and space to do the more quality improvement or career development type. There we go. Quality improvement and career development type training because they're so busy. The general mood I thought was very good in the three of.
I think you need to pull it close, and it does keep.
All right. Okay.
That helps, I think, Chris, but it
Yeah.
does keep cutting out.
If I swallow it, it's somebody else's fault.
I'd rather you didn't.
Yeah, that seems better. I think the area that felt stressed was what they call the outpatient department, which is where patients who've been seen in outpatients, given a prescription for a drug, they come up and wait to collect it, and that can be an hour and a half wait at times. The system, I'm not sure I have an answer about this myself, but maybe others can think of it. The peak time for them being busy is lunchtime, and of course staff are entitled to have some time off for lunch. So their staffing, their peak time for demand coincides with their weakest time for staffing. And that, of course, puts pressure and stress on the staff, but it also doesn't deliver a good service to our patients who are sitting around, having probably sat around a while in outpatients to start with. They then sit around perhaps to get an item. And I had a brief discussion about the potential for actually liaising with the ability to prescribe direct to a patient's own pharmacy. And a lot of patients now have their own nominated phamarcies. Now, that's not something we as a trust can necessarily deliver, but there are definite efficiencies that could be to the benefit of everyone, I think, if there is some way of doing that. I think those were the key things I wanted to pick out. And from the fact that Paul's moving towards his microphone, I've probably missed something out. So I'll leave it there, and Paul can pick anything up.
Just very quick, just one thing. We asked them, what would you really like from the board? And they said recognition.
Yeah.
We get forgotten. And I thought it was quite powerful where they said that, we talk about doctors, we talk about nurses, nobody ever talks about pharmacy.
Well, thank you, Paul, for that. I think we do sometimes, but probably not enough, and they don't know we do. I think something to reflect on there, and I've been having some ideas that might relate to that. So we've done incredibly well on timing, and so I'm hoping that Richard, Andrew and Stephen, who are the last group, are going to manage the same. Who's doing it? You mean you didn't sort it in advance, Richard?
We thought we had, but Stephen's given me a look that I can't read. I think the look he's given me is let me go first. So, good. I got that right.
So I don't know if you need to turn your. That's good.
So I'm.
Hello.
Yeah. Sorry, it's a different system than we normally use because the other system's in transit from another event. So we're using a wireless system, and there's an enormous amount of interference on that side of the building, which I'm desperately trying to fight with. So just bear with me, I'm afraid.
Well, let me be brief then, and just pick up on Phil's point about the scheduling. Andrew, Richard and I were scheduled to walk through cardiac rehabilitation at 08:30 this morning, and we made our way to cardiac rehabilitation for 08:30 this morning. The lights were off, the doors were locked. I wrote down completely unwelcoming. We stood for 5 minutes, and at that point we popped into phlebotomy next door to ask reception what time they thought cardiac rehabilitation might open. Tracy on reception was delightful. She didn't know. Very helpfully, she called switchboard, put me onto them. They were delightful. They didn't know. They very helpfully suggested they put me through. They did. And the answer was revealed on the answer phone message. This department is manned, and answer phone messages are collected 7:30 to 3:30, Monday to Thursday. If your query, the answer phone message went on, is urgent, which I thought this is us, please call your GP or dial 999. We didn't do either. We decided instead to head into phlebotomy, given the warm welcome we'd had. And on that, Richard will report.
And at this point, the story gets more positive. Thank you, Arlene. Sorry about that. So, phlebotomy was a really positive visit, actually. So, just to pick a few things out. So we were made extremely welcome by people who obviously weren't expecting us. We met with Shadoth, who's the assistant service manager. He's been a phlebotomist for 10 years and come up through the ranks and now runs the show there. And we were extremely impressed with how well he knows his stuff. And he looked very pleased to see us. All his colleagues looked very pleased to see us. So it was very uplifting from that point of view, very engaging. The environment is, the one bad thing about it is it's too hot. So it was very, very warm. It would be pretty horrible trying to do a phlebotomist job in that environment, and more horrible, I think, as the summer progresses. But apart from that, it was a good, clean, tidy environment. The fire escape clearly labelled. They all knew who their fire wardens were, and they'd all been properly trained, so that was very positive. They've got 7 bays for patients. I can imagine it might start to look a bit crowded when it's very busy. It wasn't busy at the time that we went. But in terms of activity, they told us that they do something like 250,000 blood tests a year. And when we were asking questions, so they do blood tests in that department. They serve outpatients 5 days a week. They do domiciliary visits. I don't think we asked how many days a week. And they cover the wards 7 days a week and go out to the wards to bleed people. So they're a pretty busy bunch of people. When we asked some safety questions, something that really impressed me was that in the last year, out of 250,000 blood tests, they've only had 5 needle stick injuries. I don't know what the benchmarking is, if indeed it is benchmarked, and they seem to have gone up, haven't they?
Richard, because we're running out of time.
That's fine. But anyway, I thought it was very positive. The other safety issue in a phlebotomy service is wrong labelling of blood. And they said that tends to happen more when the printers go down on the places that make the blood requests, and they have handwritten blood requests, and then it's easier to make a mistake. But there were overall, we got the impression that they knew their jobs very well in terms of safety. And I think the only other things that I would pick out, they said their local IT, having talked about printers and computers going down, their local IT systems work very well. They were very positive about it. And I think the last thing we pick out is probably when we asked them about morale, there was a mismatch between what they told us about morale and what we experienced. So they said morale is not high, primarily because of pay issues. They're not well paid, and a lot of the phlebotomists are band 2, whereas at St George's they told us phlebotomists doing the same job would be band 3, and there's some attrition and turnover from ESTH to St George's. We got the impression that they thought some of that was being looked into through a business case, but we didn't hear the details, and I don't know the details. But turnover and pay was an issue for them. But although they said that about morale, if you ask me how we felt about morale there visiting, it felt extremely positive. I think that those are probably the highlights, actually.
Thank you, Richard. I'm being very indulgent, Andrew, because we're over time, but go on. Since you're relatively new, it would be unkind not to allow you to speak.
Thank you, Chair. I totally agree with that. Felt well run. The other thing I'd pick up, Richard, is they do paediatric phlebotomy. They support Queen Mary's Hospital for children, so the phlebotomy there's a 3-week wait, though, for children for phlebotomy at the moment, which seems significant. And there's also often a bit of a wait and a lack of capacity for domiciliary phlebotomy, because that is bottom of the list in terms of prioritising staff to go out. So I would say that's quite important.
I agree. It's certainly worth us hearing. I'm not sure people can hear me. I can't get it to work right now. So thank you very much indeed for that. We had a lot of feedback, and I think a lot of important points which couldn't possibly summarise. Some very consistent messages which we're familiar with, particularly about estates. I think on the whole we found happy staff, but there were a number of specifics which I know are picked up and will be attended to, and we do get a report back on that periodically. So I'm going to move now into the formal board meeting, just 3 minutes late actually, but there you go, life's imperfect. I want to welcome a couple of people in particular. I want to welcome Jo Hunter, who's sitting in the audience, as this is attending a board meeting is part of her NHS Leadership Academy Nye Bevan programme. She is required to attend 2 board meetings, so she's joining us today. I might ask her at some point what she thinks, and she's had advance notice before I just said that then. And also to one of the George's governors, Afzal, who made it out to St Helier. So a very warm welcome to both of those and the other people in the audience. Our apologies today are from Aruna, from Jacqueline, and from Andrew Asprey. Otherwise, I think we're all present and correct. And this is an important stage, I think, in the development of the group, because this is the first time that we will have the boards meeting in common, and there is a report on the agenda which we've already agreed, but in terms of of public accountability, which explains the mechanisms by which we're doing this. We remain two separate trusts, but it's a much more efficient way of us doing business and maximising the opportunities for effective working and to benefit our patients. So I hope that everybody finds the meeting congenial. There's a lot of us, so I think we will have to be quite disciplined about things. There's another welcome I should have said to Ralph, who's here representing James in James's substantive role, because as we know, James is acting chief executive at the moment. Item 1-2, declarations of interest. If we could note, I think we're familiar with it all. Is there anything new that we need to declare? No? Okay. We've got a lot of minutes of previous meetings, and I'd like to go through all of those, if we may, very quickly. So if we take our last board meetings at both St Helier and George's, that's our 2 months ago meeting. Are people happy with those minutes? Yeah. Then we've got a meeting that we held concurrently on the 6th of... Oh, are they? Oh, sorry. Ignore me. It was only those that we needed to agree. Jane, Stephen's just reminded me that the other minutes are actually not for this meeting, they're for the next meeting. So, in fact, it was much easier than I thought it was going to be. So, thank you, colleagues. Action log and matters arising. So, of course, at this moment, my diligent disappears, and I have to load it back up again. So, I've got people busy trying to help me, but it's much easier if I have it in front of me. So the first item, I think, is the one about the message to staff about not having to put up with abuse. And of course, Peter referred to some of the feedback we got from staff about that. This has been around for a while, and we keep getting an update. But what's the current update?
The current update is that we're meeting with a couple of key departments to try and look at what we can do to support staff better. And we met yesterday with the emergency department at St George's, and they had a number of very practical suggestions relating to security, relating to body cameras, relating to other things that would make the staff feel more secure in that environment. And so what we're planning to do is engage with a couple more departments that represent the different kinds of environments that we've got across the group, and then actually have some practical actions we can take, as well as some supportive messages that we send to everybody.
Thank you, Richard. So does that mean we've abandoned the idea of a message?
No, not at all. But the feedback we got was that if we didn't put some practical points in there to show people what we're actually physically doing, then it might not be as well received as if people could see some commitment in terms of practical steps, particularly in the emergency department.
I think that's really sensible, and I think I've had some feedback about endless notes. You know, we're busy people. Sometimes talking to us is so much better. So I think the mix that you've described sounds right to me. So you'll come back to the next meeting with a further update?
Yeah, indeed, yeah.
Did you want to ask a question, Peter?
Well, Jenny, it was just to make the link back to our report back, that if you could, or somebody could pop into the dialysis unit, it would kind of give the sense of an immediate response.
Yeah, they would get. They would recognise. Actually, it's the point about recognition. They'd said something, and something had happened as a consequence. That's a good point, Peter. Is that all right, Richard and Arlene?
Yes, absolutely fine. Okay.
Welcome, Richard. And the next item is an infection prevention control item. So, again, oh yes, Richard, this is for you as well, isn't it? You were reflecting on some aspects of this.
I think perhaps the best summary would be that what Arlene and I thought would be most useful would be to put something in a structured way through at regular intervals to Quality Committee that would probably form part of the Infection Prevention and Control report, but would actually set out all the assurance around our surgical site infections in quite a detailed way across the group.
Okay, that sounds very sensible. So if we could close that item on that basis, and the first item remains open. So that takes us on to item 1.5 and the Group Chief Executive's report. James.
Thank you, Gillian, and I think my microphone is working.
It won't for very long.
I'd like to start by just noting Jacqueline's absence. As most people are aware, Jacqueline is taking an extended period of leave. She's been unwell. I have been in touch with Jacqueline on a number of occasions over the past month, and I'm pleased to see that she is recovering well and resting well, and we look forward to her return early in the summer. Andrew has been covering as the Group Deputy Chief Executive, and Ralph here, as Gillian mentioned, is covering my portfolio within my directorate, and I wish to thank them both for their support. Jacqueline has been receiving a lot of notes wishing her well, and she's very grateful for all of that. Since the last board meeting, we have been subject to various periods of industrial action from different professional groups. It has been an exceptionally challenging time to work through the period of industrial action, and there have been direct and indirect effects at all of our sites and impact on the delivery of our services. Having said that, the enormous hard work and flexibility of our staff and the changing ways that they have worked have ensured that we've been able to provide safe services throughout these periods. And just picking up the comment from Paul, this is just not about doctors and nurses providing cover. Having walked around the sites during the period of the junior doctor strike, it was really palpable how so many members of the multi-professional team, including the ward-based pharmacists, were providing support and working in a different way to continue to provide safe services. We have signed off a very challenging operational and financial plan, and that is a very significant area of focus for us as an executive team through the course of this year, and we absolutely need to concentrate on delivery of that. Andrew Grimshaw will provide more details in his update, including the recent developments and next steps and how we are working with system partners to support our ongoing financial recovery. We have received the results of our staff survey. Paul de Gamma will provide more details in his update. But we're looking forward to translating some of that feedback into positive action to support our staff, and we've got some plans for focused area of support across all of our sites. We've received a visit from the National Chief Nursing Officer, Ruth May, who attended St George's for the National Student Nursing Congress, and she was welcomed onto the St George's site by Arlene Wellman and Kate Slemek. And finally, I'd like to just note that Dr. Ruth Charlton, who is the Chief Medical Officer at Epsom St Helier, is stepping down today from that role and to return to concentrate on her clinical duties. She will be replaced by Dr. Rebecca Suckling, who will assume the post towards the end of May. I'd like to note the board's thanks, if that's all right, and my personal thanks for all of Ruth's incredibly hard work and her commitment to the role. Ruth has been and is an amazing role model. Her calmness, professionalism, clarity of thought, and compassion really shine through, with a clear emphasis on her dedication to quality. So I'd be grateful if we could note that in our minutes. Thank you.
Thank you very much indeed, James. I think collectively as a board we would most certainly want to do that, and I know many of us as individuals have enjoyed working with Ruth enormously, have learnt a great deal from her, and all those qualities that you emphasised are ones that I too would emphasise. And we will miss her, though I'm sure Becky will do a splendid job. And nobody more than Ruth would want to see somebody take the place and develop in the role in the way that that she has done over the years. So, questions to James. Jenny.
It's slightly one process. Do those posts come for rotation and become time expired, or are there other reasons? I didn't want to talk about the individual, but just as a process in both the trusts.
So the roles are appointed to on a substantive basis.
Right.
So they're not like the clinical chairs at George's where that are on a rotating basis.
Thank you.
Phil.
Thank you, Gillian. Just wanted to in the start of your report, James, you talk about the new group strategy, and which is going to be published shortly. And then we talk, and then there's the piece on the staff survey. And I want to just say a little bit about how those two things could come together, because I think ultimately the strategy will be delivered by all our colleagues, and it's so important that we communicate this really deeply, and the new strategy deeply. And I just wanted you to say something about those two things.
Thank you, Phil. So we're aiming to launch the group strategy that we signed off through the private board in about 2 weeks' time. We have some final work to do with our site leadership teams across our 3 sites. But you're absolutely right that we are very keen to embed the strategy into the mindset of everyone that works across our organisations. And we want to work with our site leadership teams about how do we support our divisions, our directorates and our services to embed the continuous learning and improvement at a local level that meets the needs of the divisions and the individual sites. And we look forward to an engaging process of launching the strategy across St George's, Epsom and St Helier. And obviously we have to do this through all of our people who work across the services. And I think when we hear about the update from the staff survey, there is a direct link in terms of the planned response to the staff survey and the linkage to some of the ambitions within the strategy.
James, just on that, I think it's a really good point that Phil raises. Are we getting out and talking to staff? Because staff say to me so often, we just don't have time to read all these things. We need people to talk to us. So is it going to be kind of quite active engagement?
Absolutely. The strategy won't work if it's just a bland document that sits on our website. So through the process of developing the strategy, we've engaged with about 2,000 people. But I think the really hard work actually comes in terms of how do we translate that into action. And we really look forward to getting out and about and supporting our divisions and our services to use the strategy as a live document and hopefully to ensure that it resonates across our organisations.
Thank you. I think NEDs are up for helping with that. We're happy to do visits and chat to people about the things that are in the strategy and why they're important. So I think we should give some thought to that. I can't see any other hands, and I know a lot of the points that James has highlighted will be picked up during the course of the meeting. So are we happy to note the report, which is what we're asked to do? Yeah? Lovely, thank you very much. That takes us on to item 2.1 and the maternity services report. Arlene.
Thank you, Julian. I will take the paper as read. So this is the monthly update on maternity services across the group. The only thing I think to highlight is that, or maybe in addition to the report as is that the staffing continues to be a challenge on both sides, but we have managed to achieve 90% on the Epsom St Helier site and 94% on the Georges site. And the work continues to ensure that we have the staffing in the right place, because both our Director of Midwives are convinced that the staffing is not necessarily in the right place all the time. And at George's in particular, we've started some work to focus on how we review that staffing level and review the nursing templates, which are not always, which weren't up to date. And what is not in the report is the visit by the CQC to the St George's site, there was an inspection of the maternity services at St George's, and we are working through the initial feedback from that investigation. And then the other thing was that we agreed at board several months ago to commission 2 reviews. One is to the Embrace data in St George's, because they had moved into the category of 5% higher than their peers. We have secured somebody that is going to be starting that investigation, that review imminently, working with the George's team. And similarly, we have secured a group of people to review the culture across maternity services at Epsom St Helier and St George's, because we can't do them separately, as we were told. So, and that is all I would like to highlight, Julian, unless there's anything else.
Thank you very much indeed, Arlene. And of course, there was a full discussion at Quality Committee, but not everybody around the table is at Quality Committee. Anne.
Thank you, Gillian. Yes, it was that I was going to pick up on that Embrace review, because I feel like I've heard about that for a little while. And I just wondered when we would see some outcomes from that, because it seems to me that that's quite pressing.
Yes, it is. And as I reported, I think, at Quality Committee, while we were trying to secure the services of somebody that is qualified to do it, everybody else was as well, and apparently they're very small and very niche group of people that is able to do it reliably. So the expectation I have been given is that we will have something that we're able to bring to board by July, having done the investigation, reviewed the data, and spoken to the teams. Both of them, the people undertaking the review are going to need to come on site. They're going to come on site, they're going to speak with staff, work alongside staff, and see and feel what it feels like in the units, as much as look at data.
Thank you very much, Arlene. I've got Andrew and Derek, so I'm going to take both questions and then pass to you, Arlene, just so that we use our time most efficiently. Andrew.
So it was really just to pick up on your questioning there, Anne, because it's something we've been looking at Quality Committee, and you'll see in our report from the Quality Committee, we're very keen to see progress taken quickly on those 2 external reviews, and are very much keeping an eye on that. Aruna and I have agreed with Arlene in terms of reference for the culture review as well, looking at what came out of the Kirkup review and what we've heard from St George's particularly as well recently, to make sure that the culture review covers all the key points there. So we're confident it's got the right scope. Now, Arlene, you know, we have been putting a fair bit of pressure just to see that followed through, and I know Arlene's doing everything she can to make it happen.
Thank you, Andrew. So now I've got Derek and James Marsh. So Derek first.
Very minor, quick point, but could we add a line to the maternity services report just saying how many live births we're dealing with per year? I mean, because we're focusing in on the problems, which is really, really important, but there's a lot of really good work, and it'd be just nice to know what the denominator is. Do you know off the top of your head what it is? I'm sorry. How many thousands?
No,
how many
not
live
off the
births
top
to be
of my
managed
head.
per year?
No, I don't, but we will add it to...
2,500. just nice to have that as a one-liner for
No,
next
I think it's...
iteration.
And I was on the maternity unit at George's on Wednesday with James, and we were discussing with the Director of Midwifery that there's always a risk that we focus on problems and we don't spend enough time celebrating the fact that in both units, but in George's in particular, we're looking after some exceedingly complex patients and have some huge successes. So I think it is important that we get that balance right. But equally, we do need to attend to the matters that need attention, and we need to do it with vigour and rigour. James.
Arlene, it's good to see that the fill rate at St George's has improved through the course of March. It has been a challenge, but I'm just noting ongoing challenges in terms of the fill rate at Epsom Hospital, and I wonder if you could just comment or share with us how we mitigate that and how we ensure that the Epsom labour ward continues to maintain safe services.
So I think, Arlene, that's the only question, because we've sorted out, I think, Derek's point. We said yes to it, and we'll provide the information. And Andrew was offering further clarification. So.
Yeah, thank you. So on the question of labour ward staffing for Epsom and St Helier, the first thing to say is that we have now appointed a new director of midwifery who is able and has been able to bring different eyes to midwifery across Epsom, St Helier and St George's, which is Epsom and St Helier, which is really good. For staffing of labour ward, there is a process, and which we have now implemented as George's as well, where all the staffing is reviewed at a huddle in the morning, and staff allocated to ensure that labour ward is covered adequately, depending on the number of women they have in there. The one further action is that huddle, the report telling us how staff have been allocated depending on what they have, is sent out to all the execs so that we're able to see in the site. There is visibility across the site of what is happening on the labour ward. So we are always content. That report also tells us what moves they've had to make, if they've had to close the birthing centre, for instance, if they've had to cancel anything, if they've had to move people into clinical who are not doing clinical work. So there is a robust process for doing it. Same now in George's, but I think the additional assurance that we have is that we are able to see that on a twice-a-day basis, what they're doing or what's happening on the labour wards.
Hands. So we're actually asked to note, to review the report and to note the assurances regarding Safety Action 9. So I think we've done the review bit, and are people happy to note the assurances? Yeah, lovely. Thank you very much indeed. So that takes us on to the Integrated Quality and Performance Report. I'm going to ask James if he'd make some introductory comments, and then I will ask James Blythe. On each. So far we've managed to a nice blend, I think, but I think it would be almost impossible in relation to this item. And the way I'll always do it, whichever site we're at first, that'll be the one that'll go first, in case you wonder why I chose James Blythe first and Kate second. There was method in it. But James, did you want to say anything by way of introduction?
Yes, please, if I may. And perhaps when we cover the Epsom St Helier elements of the IQPR, I could also invite Thurza to comment on the integrated care components. So I've got a few general comments and then some site-specific comments. So as ever, the IQPR shares a mixed picture of successes and ongoing challenges. I think we should note the extremely challenging operating environment that we're working in, and should acknowledge the efforts of staff during the recent episodes of Industrial Action to maintain what generally is quite a good performance across the group, as well as the impact on our patients who have had outpatient appointments or procedures deferred. The details will be picked up by the managing directors, but a few general themes. In terms of cancer, we've made really good progress over the course of the past year. Epsom St Helier have sustained excellent Performance and St George's have worked really hard to improve their performance, and this was noted by a letter of thanks from Royal Marsden Partners, who have acknowledged the reduction in the numbers of patients who have been waiting more than 62 days for definitive treatment from referral. In terms of urgent and emergency care, we maintain good comparative performance against our peers on the key national target in terms of patients who are waiting for 4 hours or more for discharge or admission. But we are clearly not where we would want to be, and we're not offering the level of service that we would like. We've made really good progress, particularly at the St George's site in terms of ambulance handovers, but on both sites we have challenges with patients who have been waiting 12 hours or more in the emergency department, and I'd welcome comments from the managing directors relating to that. In terms of planned care, again, George's and Epsom St Helier have good comparative performance against our peers in London and nationally, and there's been a significantly improving trajectory at St George's Hospital, but ongoing challenges at Epsom St Helier for patients who've been waiting 52 weeks or more, which I'm sure that James will pick up. We should note the really good achievement of almost entirely eliminating patients who've been waiting 78 weeks or more, and now the attention moves towards 65-week waiters. We do have some opportunities to improve our productivity in terms of theatre utilisation and patients having access to inpatient elective care. With regard to quality, I think we should note and have a discussion about the recent Never events that have occurred at both of our sites, and there are challenges at St George's in terms of the numbers of patients who continue to develop category 3 and 4 pressure ulcers, and at Epsom St Helier, challenges in terms of the mortality rate and compliance with VTE documentation. And then finally, with regard to integrated care, I think we should note the ongoing progress with reviewing the transfer of care, particularly at Surrey Downs Health and Care. And it's good to see the high number of referrals for urgent community response, but that does present a challenge in terms of our ability to see people in a timely way. So I'll pass over to James first, if I may.
Thank you very much. And Thurza, my apologies for missing you out. It was an oversight on my part. James.
Thank you. So I'll try and add to the comments that have been already made and possibly focus in on a few areas. I think the first thing to say is just to note that we were concerned with our cancer 62-day performance after we fell below the 85% standard for the first time in several months here in January, and we were pleased to see that we were able to get back up again in February. I think that this is going to be an area of sort of continual focus for us, because as the numbers accessing cancer pathways through 2-week rule methods increase, we should expect to see an ongoing rate of conversion onto 62-day pathways, and therefore it's really important that the quite considerable work of coordinating pathways of care, both within Epsom and St Helier and also with other providers, with the Marsden and with St George's, continues, so that we manage to maintain the speed of access around that 62-day pathway. I think that's absolutely critical. I'm also really pleased to see the progress that we've made on diagnostic weights. So although we're not back within the normal thresholds, our number of patients who are waiting longer than 6 weeks for a diagnostic has significantly decreased. Again, I think this is an area of ongoing focus for the board. We have not so far been successful in securing a community diagnostic centre scheme for Epsom and St Helier. We had hoped to proceed with a scheme based in Wallington, but it's not been possible to at the moment because of the availability of capital. But we are continuing to discuss that with the system, because our, when we look at the increasing demands on diagnostics from a community such as the ones that we serve, our assessment would be that continuing to accommodate those diagnostic volumes within a hospital estate such as we have will be extremely challenging, and so that's something that we need to continue to focus on. I think that in terms of 52-week waiters, we have now got a real focus on two areas, which are around gynecology and paediatrics. And again, I just highlight to the board the paediatric challenge that we have is particularly around community paediatrics. We've discussed this before. It is a very complex and very interdependent service where it relies both on other agencies, and the workforce is also very, very heavily engaged in doing work for other people as well. There is a discussion with the Directors of Children's Services of the local authorities next week, where we're hoping to explore some resolution around that. In terms of urgent care, I think the thing that I'd like to highlight is that we are extremely focused on making sure that coming out of winter, we move from a position whereby we've been very, very focused on sort of the core standards of safety around urgent care, but actually we want to make sure that we're refocusing on experience and outcomes. And actually the 4 and 12-hour standards are very important in terms of experience and outcomes. We know that the 4-hour standard challenges are largely driven by what happens to patients that we don't admit. So we know that there are delays in when we have a decision to admit a patient, we know that there will be delays in terms of getting that patient into an inpatient environment, and that is often driven by flow. But we do need to make sure that where we're not making a decision to admit a patient, that we do strive wherever possible to see and treat and discharge them within 4 hours. Some of the key challenges we have are particularly around paediatric volumes. So our paediatric A&E volumes have gone up very significantly, and we generally only admit about 1 out of 12 children from paediatric ED. So we need to make sure that wherever possible, we're seeing and treating those patients within 4 hours. On the 12-hour decision to admit metric, we have had an improvement, which is very positive to see, as that number had increased significantly. What is absolutely key to this is about maintaining flow through the hospital on the day. We have discharge lounges at both Epsom and St Helier, maintaining access to those discharge lounges, so not needing to turn them into bedded areas when we're in crisis, is a really important part of maintaining flow. And the second area that is helping with some of the significant improvement in terms of reducing 12-hour DCAs is improving our identification of discharges for the following day. So generally we are coming into more patients who are identified as definite discharges on the morning, and those definite discharges can then largely go to discharge lounges, unless there's a good reason not to, and that gives us some immediate flow out of ED. So I think that it's extremely important that we maintain that capacity to move patients through earlier on in the day, because that's in turn what allows us to reduce the 12-hour waits in the department. Thank you.
Are you going to cover the Never events? Who's covering the Never events? Who's going to do that? Because it's a Swelliok issue, isn't it?
At the Epsom St Helier site.
Yes, yeah. I was going to try and capture the Epsom St Helier things, and otherwise I think it could get quite messy.
That's
So
fine.
could you just, whoever's
Sure.
doing it, could you cover it now, and then we'll deal with all the ESTH questions.
So the IQPR refers to two Never events that happened at ESTH. One was a retained guide wire. So when we put a line into somebody's neck, a central venous catheter, we use a guide wire, and the operator inadvertently left the guide wire in the patient, and that was discovered quite quickly. And that should never happen if all the right safeguards are put in place, but through error it did. The level of harm to the patient was very low, I'm pleased to say. There was a never event in March in Swelliok in which a nerve block was performed, so it's an injection rather than surgery, but it was done on the wrong side. The wrong nerves were blocked. And that was a mistake whose essential root cause is that the side was not marked before the procedure. So there's some very clear learning there. There's some other learning as well. Again, the level of harm to the patient was low, but the procedure had to be repeated on the correct side. And although this paper doesn't say so, we have actually had another similar never event in Swelliok with a wrong site nerve block. And so steps were taken straight away after the first never event to make sure that the side is always marked in nerve blocks. But unfortunately, in the marking of the site was not visible because the drapes concealed it. So we've now taken some additional steps to try and make sure that that gap in our processes is sorted out with some clear guidelines around marking and also transparent drapes so you can't fail to see the mark. So these are three events that ought never to happen, which have not harmed or significantly harmed the patients, but which show us that we always have room to improve our processes in terms of the multiple safety netting to protect us against human error.
Thank you, Richard. That was really clear. I'm grateful for that. So questions from colleagues on any of the ESTH points that have just been covered? Anne, Phil, and Chris, in that order. I'll take all the questions and then go to answers rather, or we'll be here forever. Yeah.
Okay, I'll try and be brief. So I was reading the section on mortality, where it talks about the shimmy measure continuing to rise, and there being higher than expected mortality at St Helier. And I wondered if that was being reviewed by the Quality Committee, because obviously that's something that we would want to be on top of.
The short answer is yes, but I'm sure Richard will have more to say, Anne. But let's hear from Phil and then Chris.
Thank you. So James, thank you for mentioning the long way to paediatrics. I just wanted to say that the numbers have gone up significantly in the month, from 136 to 171, and I'm glad to hear that. But it really is critical, I think, that we get our hands around this and try and reverse this trend. It's a very, very long time for young people to wait.
I'm sure James will add, but I know it's something he's been paying particular attention to. Chris?
Thank you. It's a question in a sense for both the Epsom St Helier and the George's side of things, but I'll ask it's the same question, so I'll say it now. That is, to try and improve the efficient use of outpatient resources, what are we doing to increase the use of patient-initiated follow-up and virtual appointments? Thank you.
Thank you very much, Chris. Richard, did you want to reassure Anne or assure her that the Quality Committee is all over this by saying a bit more? And then James, if you could perhaps just respond briefly to Phil's point and Chris's about PIFU and other outpatient issues, which Kate might then want to add something to.
Thank you. So yes, Quality Committee pays a great deal of attention to this, and there are regular reports to Quality Committee about the way that we're trying to approach this and dissect it out. I'd summarise by saying that we've taken a two-pronged approach. One is to examine to what extent this may be a data artifact rather than an actual quality problem. And that's quite a complex issue to dissect all that out. And I would say in summary that there is a suspicion that some of the ways in which we record our data in terms of same-day emergency care may artifactually push up our SHIMI and HSMR, particularly if other organisations don't record their data in the same way, because this is national benchmarking. But at the same time, we've always adopted the approach that we should not assume this as a data quality issue. We should assume this as a genuine quality issue, because that's the safer and more proper assumption to make. And we've looked repeatedly at different patient groups where mortality appears to have produced a higher signal than we might expect to review our quality of care. I won't try and summarise all the different ways in which we've done that, but I think a summary of that would be to say that we can't find an individual patient group that can be readily identified which accounts for an excess mortality. And the last thing I'd say is that under those circumstances, the right thing to do, I think, is to look at areas where we think that we have issues where we can improve, even if we can't link them to these mortality figures. And James and Ruth and I and others have been doing a great deal of work, in part prompted by Health Education England and the feedback that our junior doctors gave us about the regularity with which our inpatients see a senior doctor, see a consultant, and making our processes within medicine, in St Helier Hospital in particular, more robust in that regard. And that's a work in progress, but a lot of work has been done on that. James may wish to add to that, but I think that's
hope not,
important.
because we're quite tight of time.
Sorry.
And I do want James to talk about the community peds and PIFU. Yeah.
Yes, so just very quickly to add on to the mortality, I think that it's also of note that one of the planned investments that we're bringing forward as part of the annual plan for this year is to extend critical care outreach on both sites as well, which again, going back to Richard's point, we can't necessarily attribute a cause and effect in terms of the mortality that we are seeing, but if we look at what other similar organisations have that might have lower mortality rates, they do have 24/7 critical care outreach, and there are some indicators around, for example, cardiac arrest numbers that indicate that that is the right thing to do. So we're not sort of waiting to get a definitive answer where we think that there is a targeted thing that we need to do. For example, the work around the junior doctors and critical care outreach, we are proceeding with it. On the community peds, just to assure Phil that there is a quite detailed plan that is being formed. It has a number of strands, some of which are quite sensitive conversations with the local authorities, some of which are also conversations about additional capacity as well as mutual aid across providers. So it's something that I can probably cover a little bit more on another occasion, but there is quite a detailed plan and weekly meetings with the service to try and get a different trajectory in place. In terms of the use of resources, point from Chris, I think what I would say for ESTH is our PIFU rates are good and they're continuing to go up. We've got considerable advice and guidance usage as well. I think that what we're increasingly seeing is that we now need to start to plan much more explicitly for this particularly within consultant job plans. Quite often this is something that we've been sort of able to squeeze into consultant work so far, but the volumes of it are such now that actually it's becoming a very significant area of workload on its own. And so I think for it to continue to grow, we're going to need to start to plan much more explicitly for it. I would say that there is a growing maturity of understanding of which of those techniques works in which specialty, and not all of them work in every single outpatient specialty. And for some outpatient specialties, I think what we actually need to be doing is providing more specialist input to primary care held MDTs, which is something that Thursday and I have explored that we want to start working on over the next year.
Thank you, James. That's really helpful. I can't see any other hands. I'm not encouraging them because you'll see that we were allocated quite a short amount of time on the agenda for this, in part because both finance committees and quality committees do spend a good portion of time on this, but I don't want to in any way inhibit the right debate, and there are people who don't hear some of the things that those of us who attend certain committees do. So I think we can move on then to... I was going to go to you, Kate. I was going to do Thursday. I was going to do James, you, and then Thursday. Is that all right?
Yeah, absolutely fine. Sorry, Gillian. So very quickly, a few highlights I just wanted to, and I'll pick up the PIFU point as well. So emergency department, I think we've seen some good improvement. Our 4-hour performance has always been good, but we've seen improvement around ambulance handover and also 12-hour delays, and we're working really, really hard because that's the weak underbelly at St George's, to reduce those down further, and we've seen further success with that. And that the work we're doing around that is focusing on frailty, same-day emergency care, really in focusing on the internal professional standards, but also the regularising flow programme, which is much more embedded now in the organisation. James touched on cancer. We've seen quite an improvement in our 2-week weight performance. That has been largely driven by breast and lower GI. And breast particularly, I think, continues to be a challenge specialty without a doubt, and we cannot take our eye off that ball. But we have seen a significant improvement in 2-week weight, and therefore have met our faster diagnosis standard for the first time in quite some time, and we want to try and maintain that. Our 62-day performance is still not where we want it to be, but that is partially linked to us bringing our backlog down, which has gone to below 100 for the first time. And I think our big issue is maintaining that. We've had a little bit of a tip up with the strike action impacting upon some of our cancer performance, but we obviously plan to bring that back down again. Diagnostic weight, and just to apologise to Anne, because it was raised in the quality committee that it implies that 98.2% of patients are not being seen within 6 weeks. Of course, they are being seen within 6 weeks. Significant improvement on where we were before. A big driver of that is getting endoscopy back on track, which is obviously a big volume specialty, and keeping everything else in a good place. So that's positive as well. There's been loads of work and continues to be lots of work around our theatre utilisation, which is showing much more improvement. Clearly, there's still quite a long way to go, but I'm quite pleased and proud to say for the first time we brought Queen Mary's up over the 80% mark. In fact, uncapped it's 88%. Count uncapped, but they've worked really hard to bring those cases up, and our average case per list has increased as well to above 1920 levels, so that's positive as well. As James mentioned, we brought our 78-week waiters down. They were low this from February, I think, in the report, but we brought those right down to 0 with only patient choice ones coming through now. And 52-week waiters were well ahead of the curve. Where we have our big challenge, and it links to outpatients, is patients waiting over 40 weeks for their first appointment. That continues to be a challenge for us. We have rethought our whole outpatient transformation programme. There's a lot of work we need to do. I've mentioned that before. The PIFU issue for us is very linked to us moving off ECDOF into an orders. It's an IT switch that we need to happen. It's got slightly mired in IT pressures elsewhere, and us having a date to start rolling that switch over through, and that will make an enormous difference for us being able to record and safely deliver PIFUs. You see, we're very flatlining, unlike Epsom St Helier, on PIFU, so that's an area we need to really focus on. So I'm just going to leave it there, Gillian. I think everything else is there. I'm happy to take questions.
Lovely. Thank you very much indeed, Kate. So any questions to Kate? Martin, I've seen your hand.
Yeah, so my question is more for George's, but actually affects both trusts. And I was just thinking about how most organisations, when they report in this way publicly, would identify things which are completely outside our control. And clearly the effects of the industrial action are completely outside our control. And I wonder what our approach to this is, because I guess the reason why you do that is because it gives more confidence amongst stakeholders if they can see the impact of things we can control versus things we can't control. And I guess it must also be quite demotivating for those who are putting enormous efforts into making improvements that were happening and perhaps aren't. So, in a nutshell, what's our thinking about how we and how easy is it to identify what the impact is of the industrial action on our overall performance?
Thank you, Martin. Tim, you've got a question?
Thank you, Gillian.
Thank you. Completely unrelated to that. It didn't come through in the report for me, but I know that we've spoken a lot before about ITU bed capacity, and I just wondered whether you could just remind me of what progress we've made on increasing ITU bed capacity, when more beds are going to come on stream, because I know that has such an impact on flow.
Really good question, a good opportunity for Kate, and I would help if necessary. It's a bit of a hobby horse of mine. So, Kate, could you deal with both questions?
Yes,
I can't see any other hands.
I'll start with Tim's first, and I've got IT written in big writing on my pad, and I didn't mention it. So one of the obviously impacts both on theatre utilisation, list starting late, and inability to do some of our highly complex activity is lack of ITU capacity or shortage of ITU capacity. Many of you will know we had a capital investment plan to lock on a new IT unit to the side of Atkinson Morley. That was due to be delivered in March this year. That obviously is still being negotiated through. It's got mired in increase in construction costs and everything else. In fact, Richard and I were talking about this only yesterday, and I was talking to my team about it this week, about looking at alternative strategies. We've had these discussions before, but what else can we do to enhance our ITU capacity? There are some small things we can do. There are services we can move out of capacity that could be turned into ITU capacity, possibly 4 beds, so not significant, but even 4 beds would help. We're also looking at neurosurgery, because the most impacted services are neurosurgery and cardiac surgery, both really important services for St George's, is looking at more PACU capacity for neurosurgery. That's something we're working on with the division and services. So I think probably it'd be helpful for us to bring a number of strands together and bring something back, both through probably the finance committee or quality committee, whichever is considered best, and up through the board. Because it really is a pressure and continues to be a daily pressure. And I think it's important we see the risk that we're managing in respect to having that shortfall of ITU capacity. So thank you for raising that, Tim, because I was cross with myself for not mentioning it myself. And then in answer to your point, Martin, absolutely we can, I think, ring fence. And we're doing a piece of work now looking at all of the industrial action, the lost activity associated with that, the additional cost associated with that, because we obviously are paying enhanced rates to cover junior doctor sessions, nursing sessions, and George's has had more industrial action than a lot of trust, because we have our nurses taking industrial action as well. So we're going to pull all of that together, and then there's the catch-up, which we haven't even got the cost of that yet. And as everybody knows, we're very financially challenged, so we're really going to have to make some difficult choices about how quickly we're going to catch up, given that we're paying quite high rates for that catch-up. But we should bring something back on that separate, but we can identify it separately.
Thank you very much, Kate. That's very helpful. Richard, did you want to say anything about Never events at George's?
That we had a Never event that involved a retained swab in maternity, and happily the mother and baby were not harmed by it, but there was some important learning.
Thank you. I'm just conscious that James mentioned them in his introduction, and I just wanted to make sure we'd covered all bases. I can't see any more hands in relation to George's, so I'm going to move on to Thurza as Managing Director of Community. I never get your title completely right, Thurza, but over to you anyway.
I answer to anything.
Thurza.
So I'm going to just update in relation to the 2 community services that Epsom St Helier is the host for. So that's Surrey Downs Health and Care and Sutton Health and Care. Really just to reinforce the comments that James Marsh made. In both of those partnerships, we also have the lead responsibility for the transfer of care hubs. Transfer of care hubs actually look at people that are medically fit to leave hospital and facilitate their discharge back into the community. That gives us great insights, which are now being developed also at George's, to understand where we should be focusing our attention in terms of helping the discharges. And there are quite different insights for Surrey Downs and for Sutton. So with Surrey Downs, our focus is very much around people who need long-term care on leaving hospital, the availability of care home beds, and the effectiveness of our process to work with families, with carers and the individual to ensure that the person is transferred appropriately and in a timely way. And that work is continuing. We've seen some improvements in terms of people who require that for the end of their life, so for palliative care. And we're focusing also upon people who continue their care in the community. In Sutton, the focus is very much around people who might historically have gone into community hospital beds, and how we can look at providing the care for those people within the community in their own homes, wrapping around the virtual ward and support within the community. To do that, and it's one of the learnings nationally around virtual wards, is that they cannot run in isolation of other services. So we're now looking at how we bring our virtual ward service together with our at-home service to provide a more holistic package of care for those patients. Both of those will make a big impact in terms of flow through the hospital, but more importantly, quality of care for patients. And then the only other thing that I would highlight is around, as James said, to our urgent community response. So the numbers of referrals, particularly in the Surrey Downs area and especially from Epsom A&E, has gone up very largely. We have taken a decision to maintain a safe service, but to absorb the number of referrals that we have. That has a cost in terms of how close we are to reaching the 2-hour response rate. Other community services across the country will tend to close their books and not take the referrals. So we are sure this is the right thing to do. We are monitoring very carefully both safety and also responsiveness, but we think that particularly over winter pressures and strikes, it is right that we continue to keep that service open. I just wanted to highlight that.
Thank you very much indeed, Thurza. Could you just confirm that we're making progress with nursing homes in relation to end of life? Because I picked up on a recent visit that was a struggle, and I think you and I had a brief word about it. You mentioned it there, but do you feel we're actually making progress?
So yes, we definitely are. We brought a more detailed report to the Finance and Performance Committee. We've looked at the pathway in terms of where the delays are. We have the actions which are in relation to working with the wards from the time that they identify a patient to the time that the referral comes to the continuing healthcare team. We know that the continuing healthcare team sees all of those referrals within 1 day of receipt, which is very speedy, and we're working both with our local hospices and also care homes. We have a increased level of support to our care homes to allow them to feel able to take patients who have palliative care needs.
Thank you. And our patient story today is about the virtual ward, isn't it? Which is excellent. So questions for Thurza? No? Well, you had your question from me, Thurza. So thank you very much indeed for that. So we've had, I think, quite a thorough discussion on a whole range of aspects across the 3 elements. And as usual, we're simply asked to review the report and note the operational performance. Are people happy to do that? We're also running a bit late because, as I said earlier, that we allocated quite a short amount of time for a complex report. So I'm hopeful that we'll pick up time. And if I don't feel we are, I'll turn into a nag. So just so you're all forewarned. Item 2.3 is the finance report. And I was thinking, Andrew, we might catch up a little bit of time there, perhaps. Over to you.
Depends how slowly I speak. There is no group position to discuss here because we are legally required to report the trust financial positions separately. Epsom St Helier, we expect to conclude the audit. We're reporting and expect to conclude the audit with a 35 million deficit, which is in line with forecast. And St George's, again, we are reporting now and expect to conclude the audit with a deficit of 30 million, which is again in line with forecast. So we've ended the financial year exactly where we said we would be. And just for clarity, we don't report integrated care separately because it is embedded within the Epsom and St Helier financial position within the trust.
Thank you, Andrew. And I think the important thing there is we're exactly where we expected to be. Any questions or comments on this item? No? Oh, I'm so sorry, Stephen. Yeah.
It's really just for completeness, but Andrew, are we where we expected to be in relation to the balance sheet as well, broadly?
That's a complicated question.
Okay.
Yes or better.
Okay, that's good. Thank you.
Lovely, thank you very much. So we're asked to note the financial position for George's at month 12 and separately note the financial position for Epsom and St Helier at month 12. People happy to do that? Yeah, that's great. Thank you very much. Takes us on then to item 2.4 and the NHS Staff Survey Report and Action Plan. Paul.
Okay, thank you. A bit of pressure after Andrew's very speedy response. Overall, the key message is we're pretty much the same as we were last year. There hasn't been a significant change one way or another in terms of staff survey results, and you can see that differences, which are detailed in the report, and largely they're the same. In terms of comparator organisations, just put a bit of context, compared to other London trusts, again, we're about average, which is not where we want to be, but we haven't moved down with pretty much comparable. The key themes, there are a number of key themes that are listed in the paper. Unsurprisingly, pay comes out quite strongly this year as a theme, which isn't surprising given cost of living and industrial action. Some of the advocacy scores have also come down in relation to recommending as a place to have patients, friends and family treated, and patients as top priority. And again, I suspect, given all the pressure that we've seen, that's where we're seeing some of that. In terms of protected characteristics of our staff, might be worth just saying a few words, because it's not listed in the paper, but just very briefly. From a disability perspective, the scores are not so good, so a number of our disabled staff perceive the organisation as not making reasonable adjustments as well as we might, and we're taking some steps to address that. In terms of other protected characteristics, our Black and Asian minority staff, broadly speaking, have a better perception in many areas, so that's a positive. In terms of gender, no real significant differences in terms of gender. Non-binary staff, less positive, and prefer not to say less positive. And in terms of sexual orientation, again, largely less positive for some of our LGBT staff. Less positive, particularly for staff who prefer not to say and not to declare, which is interesting. In terms of what we're doing currently, we're trying to amalgamate our culture change programs with our staff survey responses. And so what we're doing is we're looking at this over an 18-month period, and the paper outlines a number of the areas that we're going to be looking at, and our Big Five, which is something that we've been doing for the last 2 years. I'll just conclude by saying that, as I say, I think overall it's pretty much where I think I would expect it to be, given the pressure of last year, but I think there's more that we can do.
Thank you very much indeed, Paul. I think it's probably worth us noting, isn't it, that we have discussed this in private board when it was still embargoed. So the material is quite familiar to us, but it's important that we take it formally in public board, because there are some very important messages here. Peter.
Thank you. And just 2 quick points on the comparator information on the London-wide position. It was striking that UCLH is top in all bar one, and I just wondered if, or is it just that they're better at kind of managing the process? And the second is, in a way, positively, that the gap between trusts is not that significant. So it suggests, with the kind of things that you talked about, action plan, it should be possible to move us up if we deliver on those. Thank you.
Yeah, I think.
Thank you, Peter. I haven't seen anyone else for now, so please do answer.
I mean, the easy answer with UCLH is they've got fantastic building and they've got great IT, would be the easy answer. But I suspect there's more to it than that, and I suspect some of the way in which they work, some of the, I think there must be more to it. But at a really high level, I think that would be the easy answer. But it's certainly an organisation that we should look to and see what are they doing that we could learn from. But you're right, they're probably the outlier. Most London trusts are very, very close. So on an engagement out of 10 score, most organisations are around 6.8. They're 7.3. So they are higher, quite a bit higher than organisations. And as I say, I think there's something we can learn.
Is it true, Paul, that they don't have quite the same pressures as a lot of hospitals, because they're very much central London, very much tertiary? I mean, I'm not trying to find excuses. because they do stand out, and it does make you say, well, what are they doing that we're not doing? But I wonder if it is a good comparator, and your point about some of the others are probably better comparators. There's a question mark at the end.
Yeah,
of that.
I agree. I don't. It's really easy to make excuses and go, they're better because, and I think we should try to learn. But actually, I'm probably more concerned by the kings of the world and people like that who I think are more similar to us.
I think that's right. Martin.
So we had this discussion in the People Committee, and I thought it would just be worth highlighting that I think where we got to was that actually comparisons with overall with organisations isn't the most helpful approach. It's better actually to break it down by subject, and when you do the benchmarking, to look at what the best place is in the different areas, because that way you get a more granular effect, because otherwise there are so many potential influences on it. And the other thing was that where you are looking at comparing to other organisations, the evidence suggests that it's better to look at ones that have managed improvements. So it's more about where they've come from, where they got to, rather than an actual snapshot of a point in time. Thanks.
I think they're really good points. Thank you, Martin, for highlighting them. I wonder as well, as there's a question about the balance between what is done at organisation as a whole, so the Big Five, and what is actually done by teams. I mean, I think you actually move the dial by working in those areas that are really struggling. And I just worry about whether we get the balance right, whether there's a tendency to say, oh, we're doing the Big Five, and that lets teams that really need to do some really focused and often difficult work a bit off the hook.
It's a really good point, and like Kate, I had that written down and I forgot to mention it, not about ITU, but what we've done this year is we've broken down every department, so we've got everybody from the most engaged to the least engaged, and what we really want to do is to understand what makes those top 10, for example, what makes the bottom 10. And so you're absolutely right. I think the Big Five is the organisational piece that we're doing across the to understand what our response, but we're very much looking also at individual areas and trying to understand what they're doing and putting into place localised plans. So every area has had their own staff survey results that they can look at and plan against.
And are they held to account on that?
It depends on what you mean by held to account. I mean, ultimately...
Well, you have a plan and you don't really do very much about it, kind of thing. That's what I mean. So I've got two hands going up here. Maybe we should ask the managing director.
No, that'd be good.
So I saw Kate first and then James.
Thanks, Gillian. I mean, I think it's really important to look at internal schools and departments that are doing really well and departments that are doing less well. There's quite a lot of we're doing quite a bit of triangulation. There's triangulation around leadership, appraisals. You can actually see some of it's not complicated or unsurprising. I'm sure Martin would agree. But there's something about learning from where services are coming up with really positive scores and those that are obviously at the other end of the spectrum. So we are doing, I think that's as useful as learning from other organisations, if not more useful. So we are going to definitely, and you're right, it's about, if you can see the triangulation around poor appraisal rates, various things that do make a difference, because one of the things we know that staff want to discuss their careers, their futures and their development, and people are not doing that, it leads to dissatisfaction. So in many ways it's not complicated, but we do need to get into the detail and intend to.
Thank you. James?
So largely building on what Kate says, I mean, I think generally when we see that we have a particular challenge with, say, the engagement score in a particular area, we're looking to understand what sits behind it. There are some areas that I would say we know are extremely challenging areas to work in and where we will always try and support staff as best as possible, but we know that there are going to be significant challenges, and often that relates to volume and throughput. I think the focus in terms of the action plan on things like reducing the impact on violence and aggression is entirely right, because those are areas, in some of those very high throughput areas, that we know have a big impact. In other areas, what we get to is there is something going on. Sometimes it's about working patterns, sometimes it's about culture and leadership, Sometimes it is about the infrastructure and support in those areas. And I think what we seek to do is hold areas to account for the specific things that need to be addressed, because if they're impacting on the staff experience, they're often impacting on the outcomes and the productivity and the patient experience as well. And actually, it was really good hearing the feedback from pharmacy from the visit this morning, because although there are still challenges around recruitment and retention, we know that pharmacy is an area that's been a challenge within the staff survey. We also know it's been something that's come up through previous board walkarounds as well. And there has been significant work done on, for example, that implementation of 7-day working, because we know that's been a significant factor in previous staff surveys. So, and also comes up through other sources of information about how staff perceive their working lives. So I'm not sure we hold areas to account for improving their staff survey score. I think what we look to do is hold them to account for improving their service, and then you would expect to see the staff perception of the area that they work improve with that.
Thank you. I think that's a really helpful discussion. Were there any other points people wanted to raise? Yin.
Sorry, this is just in terms of the big five around the inclusive behavior within teams. I just wondered about the question regarding reasonable adjustments, because I think there was a negative deviance from 62% from 72% for the acute average. And I wondered whether there was anything that can be done to, are there any quick wins that we could potentially look at to raise the score?
Paul, I think that is one for you, isn't it?
Yeah, no, absolutely. I think there's a few things that we're doing. So next Tuesday, I'm taking a paper to group execs about creating a centralised budget for reasonable adjustments, and I'm hoping that gets approved. That means that takes away one of the big barriers around adjustments, which is I can't afford to do it because I haven't got enough budget. And so what we'll do is we will have that centralised budget, which I think is a real positive. But then what we need to do is we need to clarify the processes, because you can have money, but if you don't know how to spend it, that becomes a problem. So that's our plan is get the money, put the processes in place, and then communicate it. And we're working closely with our staff networks in terms of doing that.
Thank you, Paul. It's probably worth the board being aware that you and Martin and I and James, when he can be there, are meeting very informally now regularly with the staff support groups from both trusts. And my immediate feeling is I'm getting a lot out of it. We're getting some very direct feedback, and certainly I will want to reflect on how some of that feedback fits into all of this. Did you want to say anything about that, Martin?
Just so that particularly public are aware, this is sometimes called the networks. So they're networks primarily around protected characteristics. So there's one about ethnicity, there's one about disability, etc. And a lot around this issue was actually discussed at the disability one, which was yesterday, wasn't it? Day before. So yeah,
it's just a few days ago.
Yeah, exactly. It has been, but yeah, it's been very helpful.
Yes, and particularly the one around ethnicity, we got some very, very clear messages from staff there. So there'll be more of that to come, I think. So I can't see any other hands. We're asked to review the survey results for both trusts and the proposed Big Five, etc. I'm not going to read all of that out. I think given that we've had lots of discussions in private board before all of this was released, I think together we can probably reflect that we've done all of that. Are people happy to support that? Yeah, lovely, thank you. So that takes us on to the items for assurance, and the first one is Quality Committee and Common Report. Normally Aruna would be doing this because we're at St Helier, but she's on holiday, so Andrew's kindly agreed to do it. Andrew.
Thank you. So obviously the report covers the quality committees in common for March and April. There's a huge amount we've covered in those two committees, not all of which is covered in this report. And we did look at things, picking up the previous discussion relating to the mortality data. So we have been discussing that at length in Quality Committee. The three key issues, though, that are brought to the board in this report are firstly the industrial action, and again we've already had a discussion in this meeting around that, so I won't go into that too much. Worth saying, we haven't been aware of any known cases of harm that have resulted from industrial action, but clearly it's having an impact on performance, and repeated industrial action is not sustainable, puts us in a very difficult position. But at the moment, no known cases of patient harm, but we're keeping a close eye on that to look for quality and safety impact of the industrial action. The second key area is maternity services. So we've talked about the external reviews, which we're really keen to see happen. The other thing is we've looked at the immediate actions from the CQC inspection and report at St George's, and we're continuing to track the actions in response to that, both short-term and medium-term. The third thing is major trauma services at St George's. So this first came to light when we were noted to be an outlier for mortality, and that was prior to my involvement in the committee. What we've looked at more recently in the last quality committee meeting was the progress on the actions that were agreed in relation to that. They seem really sensible actions. There's good progress being made. Some key things to flag up really: the refurbished major trauma ward at St George's is going to open in May, so this month, and really pleasingly, there's been a substantive consultant appointee with an interest in major trauma started within the neurosurgery team, and that will help with neurotrauma and some of the actions relating to that.
Lovely. Thank you very much indeed, Andrew, and a very clear and thorough report supporting Andrew's presentation. Jenny.
Thank you very much. I'd agree that is very clear, and we saw no direct evidence of harm to patients, but just because it's a public board, I think we should acknowledge that all those people who had procedures delayed and all sorts of things, there are consequences for them as individuals, and I just don't want it to sound as though we don't recognise or acknowledge that. I think it's very important to state that.
I just wanted to reinforce the point that Jenny just made. So when we look for harm, we try and see an immediate link between cause and effect, and we can look at harm that happens in real time during industrial action. But actually, if we look at the impact of the COVID pandemic, for instance, when people had interrupted access to hospital services, there was harm, but we can only find that out statistically when we look at figures at a later date. So I wouldn't want us to be hearing or projecting the message that industrial action doesn't harm patients, because I think we're all worried that it does. The other thing I wanted to say was just there's a section in this report about the Clinical Ethics Committee, and we had a meeting between the site medical directors, myself and the chair of the Ethics Committee yesterday, talking about what direction we wanted to take things in. There was a very clear appetite from all the medical directors, including the outgoing and incoming one here, that the principle that we should work to is equity of access for our staff and for patient care to the ethics committees, so that essentially if you look after patients at ESTH, you get the same deal as if you look after patients at St George's in terms of being able to access high quality, well constituted ethical advice. The operational side of delivering that is quite complicated, but that was the direction of travel that the medical directors wanted to see, and if the board thinks that's right, then we can work with that.
Does that mean you think we will have a joint ethics committee, Richard?
Personally, I would very much like that to be the case, yeah.
Tim, you're our representative on what is currently only a George's Ethics Committee. Did you want to say something?
Yes, indeed. I mean, Richard and I have spoken about this on a number of occasions beforehand, and I'm personally very supportive of that. Interestingly, I had a follow-on meeting immediately after your meeting with the CMOs to discuss that, and we have a sort of a four-point plan of immediate actions to actually start to bring that together. I think one thing that is just in the back of my mind is that I think that the pace at which we move the Ethics Committee to formally, if you like, becoming a gesh CEC needs to be aligned with the governance arrangements that we're putting around that. I mean, at the moment, the Ethics Committee reports into PSQG, which is a St George's group. We need to find a way, perhaps a way in interim, of making sure that it is similarly grounded and has reporting into Epsom St Helier, because we are giving formal advice to clinical groups, and there are all sorts of implications, legal and otherwise, around doing that.
I think that's a good point, and I suspect it's the point that Richard made, trying not to get into too much detail. Derek?
And can I just add a note to that I had expressed a willingness to support work at Epsom St Helier around ethical advice to clinicians. So just if I could note that. That offer is still on the table.
Yes,
I don't know whether
indeed,
it was
that is the case. And
discussed yesterday or not. So.
I hope we can take Derek up on that, wearing his ESTH hat, given that Tim is wearing a George's hat in all of that. That sounds really good to hear, actually. I'm delighted. That's moved perhaps a bit more quickly than I thought it might. I can't see any other hands. Did you need a final word on anything, Andrew?
I don't think so, but I'm happy to respond if you think I need to.
Only if you thought there was anything that you thought had been left hanging in the air. Okay, thank you. So we're asked to note the issues escalated to the quality committees in common and the wider issues on which the committees received assurance. Everyone happy to do that? Lovely, thank you very much. So the next item, which is 3.2, is the Finance Committee in Common Report. Anne?
Thank you, Gillian. So if I could perhaps start with an apology that we would normally produce a written report for the public board. And we're struggling to get to grips with the new format of reporting to joint board committees. And the report we've got is a mixture of what was discussed in public and what needs to come to the private board. But that this will be a one-off. We will produce a written paper for the next public board. And as always, when we get to this stage of the agenda, we've discussed already quite a lot of what we discuss at the Finance Committee. So we do pay a lot of attention to the financial outturn. And as Andrew said, that was absolutely in line with where we expected it to be. And although we were only permitted to change our formal position at month 10, we have known as a Finance Committee that this would be the outcome for some months, and we take good assurance from that. We also do discuss the IQPR, and we've had a very thorough discussion on that. So the only thing I would add, and really for the benefit of governors, because I know the governors are particularly keen on the cancer performance, that actually, we are paying that particular attention at the Finance Committee, and we were assured that there was a plan that took us to green that we should achieve by September. So that's all I would say on that. We've actually probably covered a number of the items that the committees would like to bring to the board's attention. The first is the ITU capacity, that we were concerned at the lack of progress with the ITU capacity at St George's, because this adversely impacts, as has been said, not just non-elective activity, but it also knocks into elective activity, because if you haven't got enough capacity to deal with your trauma-related work, you can't take in elective patients. So that is a significant bar to taking activity, and that has a consequence for our finances, because if we can't undertake the activity and reach those targets, we won't be able to achieve some of our financial targets. But I think we've probably aired that enough. Clearly, we've been focusing a lot, it's ironic really, given that we're on the 5th of May, on the financial plan for the current year that we're now a month into. And we're not yet in a position where we can talk about that publicly. But I think what I can say is in the plan that we have put forward requires delivery of quite significant cost improvement programmes in both organisations. Across South West London, all of the trusts have agreed that we will aim to deliver 5.5% in cost improvement programmes, which is at the top end of what has been delivered in recent years. And I think perhaps more importantly, we need to ensure that those schemes deliver money recurrently, that they're not just one-off windfalls or whatever else, because that will that's what will position us to deliver in the following years, and that will be quite difficult. And I think we've recognised that that will require quite a lot of scrutiny, detailed scrutiny that we perhaps wouldn't get into normally, on looking at those plans and looking at the delivery, particularly in the early months of the year, because I think we will be under scrutiny not just from the ICS, but from London Region and from the NHS itself. And then the third point that we wanted to bring to the board's attention was around the group corporate services review. We do have a paper later in the second part of the meeting, but I think there was some anxiety that this was taking some time to deliver against targets, and actually a point that the target itself isn't actually quite clear, and there needs to be clarity on what that target is. And again, that's something that I know it's being overseen by the People Committee, but the Finance Committee will take a very close interest in the delivery of savings on that. I think I'll stop there.
Thank you, Anne. That's really helpful. As you say, two of the items do have full papers in the second part of our meeting. So are there any questions or comments at this stage? Martin, are you leaning? No, I wasn't sure whether that was a lean forward to... well, I can't see anyone, so, so we're asked to note the issues escalated to board and the wider issues on which the committee received assurance. People happy to do that? That takes us on to the People Committee, and that, I think, is why Martin was stretching across. So over to you, Martin.
Fingers on buzzers. So I'd like to focus on three areas which I believe are strategic rather than operational, and they, for me, are the highest areas of risk. So that's industrial action, diversity and inclusion, and recruitment and retention. And for each of these, I'd just like to highlight what I think where we are currently in terms of assurance. So, for example, with industrial action, I feel assured that everything that could be done is being done to minimise the risks. So clearly there are risks, but the assurance is that we're doing what we can do. And then if you go into that, I think it's important to understand that in terms of the People Committee remit, it's less around the operational position and how we cope with industrial action as more about the impact on people. So, for example, we know that it's very stressful in lots of different ways. It's very stressful for people who are asked to do jobs which they're not familiar with. So, for instance, consultants covering for junior doctors. It's stressful for people who are taking industrial action, who clearly would rather not be taking industrial action, and equally those who aren't taking industrial action. And there's lots of psychological impacts from that, and divisions within the workforce, which the longer these things go on, unfortunately, the worse they become, and even more so when unions take different positions. So I think we're hugely aware of this, and huge amount of respect to the exec who managed to cope with this, and also directly within the area covered by the HR function. There's a lot of stuff behind the scenes which you could call technical employee relations stuff. There's a lot of legislation around how all this works, etc., and a lot of advice that line managers need, which again has been done very well. I think on diversity and inclusion, I mean, obviously this is also a national issue, but I think that the staff survey again shows us a familiar picture, and I think a frustrating one, in all honesty. So I think the assurance is there, but I do think that historically this subject has perhaps suffered a little bit from having very long action lists. And the problem with very long action lists is they become difficult to review. So there is a huge amount of activity in this area, but I think it would be fair to say that the committee has been encouraging, one, a more evidence-based approach, So to look at, as we touched on briefly with the staff survey, look at what we know works and look at the data which says that, and then concentrate on fewer actions based around that. The other thing is that we have been saying for a number of years, and I know it's difficult, but I think we are still keen to see, is that some of the key data is only produced annually. And if you imagine where we'd be on finance if we only looked at something, at the end of the year and then said, oh dear, it's not where we wanted to be, it wouldn't really work very well. So perhaps at least quarterly, and that's particularly around the RES data and the WDES data, sorry for jargon, around what happens in recruitment. And those are very, very key bits of data. Hopefully we can look at them at the board at some point. And then lastly, on recruitment and retention, I'm not going to say why that's important because I think it's self-evident, but I would say that what we don't often talk about is that I think it has a huge hidden cost. A huge hidden cost in terms of people's time to recruit people, to replace people. I think it has a productivity impact, probably impossible to measure, but the more people change you have, the more churn you have in a workforce, the more it damages the productivity, and it possibly has an impact on quality as well. And I think where we are on that is, again, I think the assurance is there because there's a huge amount being done. Perhaps, again, shorter action lists, fewer actions, more evidence base would be helpful. And I think also an improvement in the data quality, which is important from an assurance point of view, because if you look in the report, for instance, it says that the number one cause of attrition is relocation. That may be a consequence of other factors rather than the cause. And it's very rare for people to only leave for one reason. And Kate also talked about triangulation of data around things like appraisal, staff surveys and so on, hugely important. So that's the overall summary, and happy to take questions. Thank you.
Thank you very much indeed, Martin. So, Stephen, I don't know if there's anything you wanted to add.
First, with three very brief things. Firstly, to associate myself with Martin's comments, I think it's important that the chairs act as joint chairs. And then probably with slightly more of a St George's only perspective, really three points I think that are in the joint report. One, just to remind us how much of a knock COVID has been and the pandemic. And we see that coming forward in two areas. Firstly, the importance of job planning for consultants. We had a really well-formed programme of activity which stopped in its tracks with COVID and is going to take 2 to 3 years to get going again. I think it's important we understand why that's happened. It's not delinquency. And the other similar issue is the initiative we had within George's to broaden the pool of consultants we were encouraging to apply for a Consultant Excellence Award. What's shown in the gender pay gap report as a bonus. And again, good plans, not sideways. So that was the first thing. Secondly, just to remind everyone, George's and ESTH, that the joint bank project is continuing well. I think it's important that we look at it at two levels. Firstly, the joint bank project illustrates the benefit of being a group. It wouldn't have happened otherwise, but it also demonstrates the limitation. One trust providing services to another. And so there's a need for a bit of an arm's length separation and negotiation, because St George's is assuming a responsibility to deliver to Epsom and St Helier. It needs to do it well. It needs to make sure it's not distracted. And there's a lot of work being done in and around the People Committee to make sure that happens. I just want to give people the assurance that is being paid massive attention to. And for both trusts, this is 12% of their workforce, their delivered workforce. So it is critical. And then the third very brief observation was to pick up on something Anne said. The group consolidation programme is being viewed from both People Committee and Finance Committee, but there's a commonality of membership that ensures there's consistency at both committees. It's not two different discussions, but the focus is slightly different in each. But there's an internal consistency. Thanks. Thanks, Gillian.
Okay, that was great. Thank you very much. So there's an enormous amount there if people wanted to have a long discussion, which hopefully they don't, given our time constraints. Anne?
I'll try not to provoke a long discussion. I was going to raise job planning because I was horrified when I saw 3 years, because obviously that's something that certainly at George's we've been talking about for, I think, at least 3 years already. But I'm assuming that you've assured yourself it will take 2 to 3 years. The other aspect, and it's the financial consequences of some of the HR processes, isn't it? The retention, recruitment that drives a need for bank and agency staff. And it sounds like you've asked for some further work on that. But what about sickness? Because actually backfilling for sickness is quite a driver at the minute of additional staff. What are you going to do with the sickness plan?
Yeah. So we've seen an improvement in terms of sickness rates, particularly at George's, which is good. I think there's more that we can be done. We've talked about this a lot in terms of our how we help managers to manage sickness, because there is that support, and there is more that can be done. I can't provide absolute full assurance here that I think we're doing everything we can do. Having said that, we're seeing an improvement. What I can say is there's a very clear plan as to how we can improve upon our current position, and we'll continue to report into the People Committee accordingly.
Thank you, Paul. Report. I won't read it all out. People are happy to do that? Thank you. So that takes us on to item 3.4 and the George's Audit Committee. Peter.
Thank you, Gillian. And I'll cover the ESTH one as well as I go through, distinguishing between that in the spirit of time, but and without duplication. So, and the reason it's an oral report, the George's one was on Wednesday, ESTH yesterday. Both had busy agendas reflecting back on the last year, planning ahead for this year, and also looking at the transition of our auditors. In the case of internal auditors, we're moving to a single auditor, internal auditor RSM, and in the case of our external auditor, Grant Thornton, who have been the auditor for George's and now also the auditor, external auditor for ESTH, which is, I think, really good to enable us to, I think, get greater clarity across the group in terms of the planning process and so on. So, and the top line, I think, that we took away from both meetings was we received a good level of assurance about the backward look, and the planning looking ahead is in good state, and the transition is working smoothly. Just a little bit of detail to add to that. A few of the items we covered. Firstly, we update on the annual report process, which complements the annual audit, and Anna has got a lot of work underway to work on that. And I think what we'll see is greater commonality across the two reports, and also at the end of it, a 4-pager, which will be for more wider usage. Unfortunately, the annual reports don't get much of a readership, but there's lots of good stuff in there. And if we can pull that out and showcase it about what we're doing, what we've achieved, what we're planning to do in the future, I think will be a really valuable asset for us all to use. On the external audit front, we were reassured by Grant Thornton that the work is happening. They're getting good collaboration from Andrew and his teams. And again, there's a requirement to produce a VFM report for each alongside the audit. And now we're having a single auditor doing it. It will help us to get more of a joined-up approach across. So I think, again, that's one small other example of coming together. Moving from external to internal audit, we heard that the 22-23 plans had been completed in both cases, both at George's and ESTH, completed successfully. We had to consider a whole lot of reports to make that happen. That Q4 is always a busy period, but nonetheless, overall, they were in generally kind of moderate assurance. Some recommendations for improvement, but none that we were particularly concerned cause a great issue. just one particular one that Andrew is following up will be coming back for our next meeting. We were told that in both cases, in fact, the head of internal audit has to produce an annual opinion to make sure that things are generally in good shape. And again, we were told that it's likely, it's not yet final, but in all probability will be moderate assurance. Now that doesn't sound terribly overwhelming, moderate, and Anne had suggested, why can't we use good? Because it may not be fully substantial, that is something we might aspire to, but moderate always, but unfortunately this is what the categories that they have to work within. So it's actually a good outcome, and the follow-up on the recommendations in both cases, again, has been working well, and there's very few outstanding actions to follow up, which is again a good sign. On the 23-24 internal audit plans for both trusts, there's been a lot of discussion and at group level, but partly because of the transition and a slightly shortened time to finalise the plans. What we received, I think, was good progress, but there's probably some further iteration. And probably the main point is to strike the right balance between getting best value from the work across the group, alongside the assurance we need for each individual trust. So do we carry out audits in both trusts or not? It's not for discussion now, but we're going to go through a bit more that cycle. I think that will be helpful. Otherwise, 2 or 3 final points. One, counter fraud, again being handed over to the new external auditors. Again, we were told there's green returns, which is good, on both counts, both for George's and Epsom St Helier. So counter fraud seems to be in a good place and working well. On cyber, it's still work in progress in terms of development of a dashboard which will enable us to see more at a glance the state of play, and Peter Davies will be reporting back, but we'll be working closely with Tim on this. Tim volunteered to help us steer the right course on that, for which we're very grateful. And finally, we heard the committee effectiveness report, and apart from the detail, I think it was Anne, you suggested it would be helpful in, say, 6 months' time, just to review. At the moment, we're still meeting separately. We're not a committee in common, but to review whether that remains the right place to be. As you've heard today, there's actually a lot of overlap in terms of the work that's been done, but obviously we need to make sure that the trust focus as well comes through. But that's for another day, and we'll come back to that next time. Thank you.
Thank you, Peter. That was very comprehensive and reassuring, certainly. Any points that, Chris?
Thank you. Just given that we've now got common auditors, RSM and Grant Thornton across the two, what value added do we get out of having those two? Could you just say a word about that, please?
Thanks, Chris. I've provided a few examples where there'll now be a more kind of consistent approach, whether it's to value for money reports or other aspects of how they report back to us, and we can more easily compare. So, and I think we're keen as well that they will be able to draw to our attention more clearly good practice within the group, but also because RSM on the internal audit side are the auditor for most of South West London trusts, including the ICS, including Anne's Mental Health Trust. What they've said to us that they will consciously draw together the best practice across South West London. So I think that should be a real positive as we go forward. Thanks.
Thank you very much. Somebody else indicate. Stephen, quick.
Ever so quickly, just picking up on Chris's point, although they're not for filing and they have no statutory value, a set of group accounts might be quite an interesting expression of the work, because all of the activity has been bought and paid for, and it might just give us a sense of the group as a whole, even though we're not going to do anything with the accounts other than use them internally.
Well, I was going to say something to think about.
Yeah, I was going to say, can we give that careful consideration? Because that is a mammoth piece of work.
Okay.
Yeah, so it is. I'm not saying we shouldn't do it, but we need to step into that in a very informed way, because, as I said, it is a colossal piece of work.
As I said, something to think about. If we could note both of those reports, I'm getting tetchy because we're running out of time, and we've still got some way to go. So, Anne, we're on 3.6 and the Estates Assurance Committee.
So I will be very quick. I won't go through all the different ways in which the committee assured itself around medical devices, but we're now well versed in them, and we actually felt that as the Epsom and St Helier Trust could take good assurance actually from how those were being managed. We've still got two more areas that we haven't yet considered. They are decontamination and high voltage electrical safety, which we do need to address. And then our plan. So we gave some thought to kind of where does the committee go. I think over the year we've met, I suppose, probably about half a dozen times. We have reviewed a number of areas, but some of the early areas required further work to be done. And I think what we need to do now is to go back to that and say, you know, we asked for some action, have those happened, and are we now in a good place that we can then hand over what then becomes ongoing normal monitoring to the Finance Committee. So I think we've got two items to cover. We've got that piece of work. I think the other area that we talked about is the continued delay in the start of the new hospital is having a significant impact on our existing estate. And we sit here at St Helier, much of which is well past its sell-by date. You know, people have done as good a job as they can in keeping it going and refreshing it and so on. But there is a serious piece of work to be done with about how much of this will actually withstand the delay till we start with the SETCH. And that becomes ever more critical. And the view of the estates group was actually that needs to be done in conjunction with the Build Your Future Hospital programme, because they are two sides of a coin, aren't they? Some of these bits we might have to shut before the new hospital opens. And so we talked at the last Build Your Future Hospital meeting about kind of bringing that together. And that might be just practically about bringing the two meetings so that they butt end each other, so we can talk about that. But that, I think, probably sits better in the Future Hospital meeting than in the Finance Committee at the moment.
Thank you, Anne. Any questions or comments to Anne, or can we note that report? Tim?
Forgive me, just briefly, I appreciate this is an Epsom and St Helier committee, and I'm just sort of mindful of the fact that at St George's, historically and continuing from now, we talk about the estates issues within the Finance Committee meeting, which is an incredibly sort of stretched agenda, really. And I was interested to read this report and see the level of depth that's been attended to on matters like medical devices. And I just as a marker, really, just going forward, really, now that we have a Group Chief Infrastructure, Facilities and Environment Officer, which is a very snappy title for Andrew Asprey, I just wonder whether there is a better way of bringing those agendas together, perhaps across both trusts, in a way that would enable us to get some shared learning and make sure we have adequate focus on it.
Personally, I think it's another one to think about, alongside the fact that Finance and Performance Committee is regularly 4 hours and remains a source of concern to me, that we therefore provide the right degree of attention at the end of a very long meeting. Did you want to say something, James?
Yes, I think if Andrew was here, he would probably say that in terms of the way that he structures the functions and in terms of some of the management changes he's already made, he is actively encouraging some shared learning and some shared processes. And I think as part of considering the future shape of that function, we'll be doing exactly that, Tim. And for example, with some of the issues that have been raised around some of the learning from recent CQC inspections, we're very much now able to adopt a shared approach because we have that shared appointment at the top level. So I see it happening already. I think that the detail that we've done with the Estates Assurance Committee so far has been to get us to a sort of baseline level of understanding, and I think we can now think about, as we move forward, having a sort of common level of assurance which is backed by some common processes.
Thank you, James. That's helpful. I still think there's a bit of thinking about that because we've got this contrast between this deep level of detail, which we did have at George's at one point, and then practically nothing. And I just wonder if there's somewhere in between. But it's to be discussed elsewhere. So if we could note that report, I'd be grateful, and move on to 4.7, which is Sutton Health and Care. For those of you who are anxious about item 4, I intend just to note those items so that we don't detain people needlessly. So, Chris.
Thank you very much. And pleased that the board has had the opportunity to hear from Thurza about the Alliance IQPRs, which I think is the first time we've heard it isolated from being buried within it otherwise. So that saves me some time in what I might otherwise have said. There is, of course, a lot of commonality between the two alliances and their aims and methods of working. So the board has the reports there. I just wanted to pick out a couple of things. One is that both alliances came within their budget for the year 22-23, which was good news, and they have progressed their calculations for meeting the new budgetary constraints for 23-24. The two other points I wanted to pick out: planning is going ahead for anticipated but as yet unknown dates for CQC visits. But for Sutton, part of the services are provided. The CQC registration is hosted by London Borough of Sutton for some of the children's services, and there is a CQC visit planned for them regarding children with educational needs. So that's not directly this board's responsibility at all, but I just thought that should anybody on the board get aware of it, that it's going ahead. The final thing I just wanted to mention is that you've got the details of what's on the integrated risk registers. Surrey Downs has for some time been very conscious of the high vacancy rate, something around 25% on community staff. And because of that, and the priority of that, has decided to put the staff survey onto their risk register as a tool to be used to try and improve recruitment and retention to Surrey Downs staff. And I think that will help focus the minds about how to help with those issues. I'm happy, if the chair allows, to take any questions or comments.
Thank you very much indeed, Chris. Anything for Chris? Okay. Conscious that we've got a lot of the community staff, well, a number of them joined us to do the patient story shortly. So if we could note that report. Item 4 on the agenda are a number of issues for noting, all of which have been properly discussed at the relevant committee. So unless there are particular... Arlene?
Sorry, Gillian. I did want to say on the healthcare infection report that we must note that for the third year in a row, F. Simmons and LA have had 0 MRSA bacteremias, and that's the position that they closed. And for George's, it was reduced quite significantly to only 1. 1 is too many, we know, but, and the work that the teams do to ensure that we get this, I think we need to recognize it here. So that's the only thing that I would like to add.
The Quality Committee, of course, recognised that and all the effort that's been made around it, but it's right, as Arlene says, that the board does as well. So I think, as I say, all the other reports, and of course 4.4 we've discussed ourselves. So if people are happy to note all of those and the particular point that Arlene made about MRSA, people are happy? Excellent, thank you very much. Any new risks and issues that people wanted to flag up? I can't think of any in particular myself. The ITU risk, I think, has been made very clear, and it's one that is exercising me quite a lot. But we've flagged that up. Any other business? I haven't been told of any, so I'm not looking at anybody. That would make me really very cross. And 5.3 is reflections on the meeting. I've asked two people to do this briefly. Thurza to give an ESTH point of view, and Tim to give a George's point of view, because as we said a couple of other times in the meeting, whilst this is a meeting of both, we still are two statutory organisations, and we need to satisfy ourselves that it works for both. So, Thurza, would you like to go first?
Thank you. So I think that considering this is the first meeting of two unitary boards coming together as a boards in common, from a perception of how we worked as one unitary board, but with a clear focus on the two organisations that we have a responsibility for. And I think that that is positive. I think that from an executive point of view, we were clear about our roles and responsibilities. We weren't talking over each other or thinking that we needed to add, and I think that that helps the flow of the meeting. And I think that the chairs of the committees reported back very eloquently and very clearly, focusing on both of the two organisations, but also the commonality. And I think that's quite a test to be able to do that. And included the executive, I have partners here, but included the executive leads at appropriate times, but with it being clear that it was definitely led from the non-executives. I think in terms of timing, there is perhaps more work to do. There is perhaps more work to do just to make sure that the balance of conversation reflects the timing, so that I think on some areas it felt that it went on longer than perhaps was required, and in others maybe it felt a bit rushed. And I think then my final two reflections, one is from the feedback from the visits. I think that we create a lot of energy and enthusiasm from the feedback for the visits, but maybe a clarity of focus of what the board wants to achieve or wants to report back would be helpful. And then just finally, at one stage I did think Andrew was going to jump out of the window, and perhaps I'd misread the meeting and I needed to report back differently what I was going to say.
But actually it was to do with temperature, was it?
No, it's a noise.
Oh, well, that's interesting. For me, it was a temperature issue. There was one point when I thought I was about to expire. It was so warm. Well, I thought your point about timing was... I thought all those were good comments there, but I found the timing quite difficult. I thought there were points when we were going on when we'd covered stuff in committee. It didn't need it. I mean, I don't think we curtailed anything too much, but I felt all the time that I was living on my nerves, as it were, trying to get us to where we needed to be. Tim?
Thank you, Gillian. Yes, I agree with a lot of the things that Thurza had to say, actually. I mean, I'm very conscious that it is our first group meeting, and it's really good to be here at St Helier, actually. I'm enjoying the day as it is. I think the formula that we use of topping and tailing this meeting with ward visits, and then we haven't yet heard the patient story, but I'm sure it's going to be really interesting, is a really powerful construct. For those of us who don't live within the hospital, as it were, that are non-execs and come in and come out, it really does ground the meeting, and I'm really pleased to see that we're sort of retaining that. I think that actually this room, if I may say so, is a good room, notwithstanding comments about the temperature and the niggles we've had with the PA system. Actually, this is a really comfortable sort of environment to be in. There's a lot of us in the room, but the acoustics work well, and we can hear one another, so that's really useful. Just a bit on the agenda and the papers. I mean, I noticed the difference in style of the papers, and I thought it worked really well, actually. I quite liked the papers in colour. I liked the fact that we were breaking out in sections and being very clear and explicit about the things that were for noting, for review, and for assurance. I was conscious that some of the papers were a bit late. We've had made that comment at meetings before, and that does make it difficult for some of us to get through some of that material. But another very specific thing here was on the cover sheet. There is a line there that says, "This paper has been considered before by," and I thought that was really powerful, actually. I think that it's important that we remember that a lot of these papers are quite familiar to us. And if some of the questioning is a little bit light in some areas, it's usually because we've quite exhaustively done that somewhere else. So perhaps that's just a point to note. Just as a sort of subjective observation, I did wonder at one point whether we were being well behaved and a little bit too polite. When we were particularly talking about the IQPR, I thought some of our questioning at that stage was not quite as in-depth as it has been elsewhere. And then my opinion changed when we got into the assurance papers. I think we gave our committee chairs a light grilling over some of the issues in depth there, which I thought was really quite powerful. And we did start to get into some of the real detailed things that we know are really important. So I think so far, we haven't got through the day yet, and I think it's been a very effective day so far.
Thank you, Tim. Well, I think so far so good is probably, I'll put it less kindly than you, but I think both you and Thurza have set a reasonable start, really, but something for us all to work at. Was there anybody else had any burning issue to share their own views of the meeting? No? Okay. Well, particular thank you to Thurza and Tim, but to all of us really, because it's, this is the first time we've all had to do it, and I think it's quite complex putting two big boards together and running it effectively and having confidence that you're doing the assurance piece well. So we've actually done incredibly well. We were meant to get to the patient staff story at 12:30, and we're only a few minutes over. So I'd like to welcome Lucy Botting, who's Director of Sutton Health and Care, Sarah Fenner, who's Head of Urgent Care and Facilitated Discharge, and Robert Oates. Is Robert here as well? Yeah, hello, Robert, who is a frailty consultant at ESTH. And this is here because I had a brilliant meeting with the staff running the virtual ward and some of the issues that have been thrown up. And I just thought it would make a great, I suppose it's a kind of staff and patient story, really. And so thank you so much for coming to talk to us. And we've got about 20 minutes. There's bound to be questions, so hopefully that you leave us a little bit of time for that. Is that okay? How are we going to manage this?
So we've got a video.
Oh, right. How are we going to watch that? We're going to move.
I think the video was so powerful.
Yes.
That we felt actually it was important. There's a couple of slides which said we can send, if you haven't got them, we can send out so you can see them later. We'll talk to it, but the video about professional impact and patient impact is really, really important.
So those of us here need to move a bit.
Where do you want us to stand and speak, by the way?
Well, probably there. Are you okay? Would you prefer to be somewhere else? Do you want to be up by the video?
No. I'm happy to go here.
Is that all right?
Yeah, Sarah's going to.
Okay.
Thank you. You all right, Sarah? You all right, Sarah? Okay. Shall I kick off anyway, given the time? So firstly, thank you very much for welcoming us and for allowing us to be here to share our story. And it's not a patient story per se, it's a service story, absolutely with patients included. And I think that's really, really important. And hopefully we'll get the video to play. As I said, if we can't, we will send around the PowerPoint. Please do have a chance to have a look at the video because it is so powerful. I feel like I'm on a stage here and I'm just about to sing, sorry. So the virtual ward that we have in Sutton is not a new phenomenon. I think that's really, really important. It's been running since 2021, so February 2021. And it really came about because of COVID. So during COVID, and we work really closely as partners across Sutton. I think that's really really important to say. So whether that's GPs, myself, I'm a joint appointment between the London Borough of Sutton and Epsom and St Helier, so our LBS colleagues. And we came together in what we call a CRT, Community Response Team, to prevent admissions, to keep the vulnerable safe in Sutton, and to look after patients with COVID. So that's how this entity was first born. It wasn't born because the government said we have to create virtual wards. So I think that's really important. And obviously, we created an MDT, so multidisciplinary teams coming together to talk about complex patients and how we prevented admissions, but also how we started to facilitate discharge. And then obviously what happened was the NHS England said, virtual wards, everybody has to create virtual wards. Now we thought, well actually we've already got this, we've got a really, really solid delivery vehicle. And we're really proud of our delivery vehicle. And in fact, we're the only ones in South West London that have 100% GP engagement. So our GPs are our responsible owners of the patient, and they remain the responsible owners of the patients during the time that the patients are on the virtual ward. So you'll see on the slide deck when you get it that actually we have a virtual ward of 100, so a bed capacity of 100. And that is split between 4 wards, so 4 PCNs, so primary care networks. And that's what we have in Sutton. They're the GP vehicles. So we have Wallington, Carshalton, Cheam South Sutton, and Central Sutton. And so they've got about 25 beds each, but we're flexible. But that's just so that we actually manage the workload well. As I said, it's led by the responsible owner, who is the GP, and they have multidisciplinary teams that function around them. So the bulk of the work, though, is delivered by Sutton Health and Care. And we have a team of 10. So we have a team of 8 nurses, 8 to 9 nurses. We have some bank nurses that come in. We have a phlebotomist, and then we also have a pharmacist. And so we deliver the care, and then we work 5 days a week with our GP colleagues, with Robert, to come together to talk about the management, the treatment, and support for patients, and that's really important. We operate 8:30 till 6 on a Monday to Sunday, but then we have our overnight team that functions. So we are a 24/7 model, and we sell ourselves as a 24/7 model. And we have South West London as a patch decided to go with remote monitoring. So sometimes we remote monitor to telehealth our patients. That comes from Croydon, and we do that with about 50% of our patients. Sarah, do you want to show us you've got it up now, thank you. I think what we've done in the last year and a half, and I will stop talking and hand over to Robert, who'll talk a little bit about the clinical care, was that we started to focus on facilitated discharge. So that was really, really important. And we already had a very good Home First and At Home team in St Helier. And what we've done is we have moved the virtual ward team right around that Home First and At Home team. So the virtual ward, while it was predominantly nursing and medics, we've now got a therapy team wrapped around the virtual ward, if this makes sense. So when we talk about facilitated discharge, we have an in-reach model, so we go to all of the wards, and that is work in progress. And again, we want to pull that out throughout this. The patients will come to the discharge huddle, which is on a daily basis, where we talk about patients for Home First, for At Home, for social care, all of the pathways that you hear about, and also the virtual ward. And if a virtual ward patient needs a package of care, social care, therapy, the patient will come out with the virtual ward, but with that package of care. So we are really trying to join the dots here in terms of synergising with other services. We also work with Home First and the Care Home Support Team, and palliative care support team, I should say. And so if a patient is deteriorating, if a patient needs end-of-life care, then actually that patient will come out surrounded by the virtual ward, palliative care team, and whoever's needed. I think that's what I need to say. So the first two slides that you have up there, and I said we'll send them round, are the model that I've just talked about. And the second slide, Sarah, if you just want to go on to the second slide, talks about the delivery. I'm going to hand you very quickly over to Robert to talk about the clinical conditions.
Thank you, Lucy, and good morning, Madam Chair and everybody else. I'll be very brief. I've been a hospital consultant for 20 years. Prior to that, I did 15 years in general practice, so I know both areas pretty well. Sutton has about 200,000 population, of which 25% are frail. That's a huge percentage, the biggest percentage in Southwest London. Okay, frail patients, when they're admitted to hospital, they decondition, they become exhausted, their muscles atrophy, and they stay a long time in hospital. Current statistics shows that the average frail patient is in hospital for 7 to 8 days length of stay, but those who are admitted from care homes, the average length of stay is 22 days. And that's 21 days too long. So, the Southern Community Virtual Ward is not a virtual ward, because a virtual ward by definition involves remote monitoring only. This is a hybrid between hospital home service and remote monitoring, because in reality, the average frail person can't handle the technology. So what we've got here is a very unique service, unique for a few reasons. It's unique because it's PCN-led, partnering with St Helier Hospital and Southern Health and Care, whereas all the other virtual wards in South West London are hospice-centric, hospital-led. Also, this virtual ward caters for anybody over the age of 18, even though most patients are over 75, whereas other virtual wards are more specific, Kingston's and respiratory, for instance. So, the main idea is to get people out of hospital faster, not when they're medically stabilized, as the saying goes, but when they're close to being medically stabilized. So the last few days they can get cared for in the community, where there's dignity, there's privacy, there's familiarity, and where patients can bond with their families, and there's less hospital-acquired infections and pressure sores, etc., etc. So any patient who has complex medical needs, any patient who's got an infection that says treatment like for pneumonia or urinary infection, a chest infection, they can get the antibiotics initially in the hospital, and the last few days of antibiotics, including IV, can be given in the virtual ward. Nurses assess them as they come home, they put on remote monitoring if they need it, they treat them in their own home, they interact regularly with the GPs, because the GP is a responsible clinician. And there's virtual ward rounds at the moment 3 times a week in the afternoon, where we give advice and guidance. There's always a pharmacist available to optimize medication, and so that's how we treat patients. The GP is a responsible clinician for everything regarding the patient, excepting where the therapy is not standard GP therapy. Therefore, in the case of a patient needing IV antibiotics or sophisticated oxygen therapies, the responsible clinician is myself as clinical lead and not the GP. So that's stepping down patients from the hospital into the community. Obviously, the idea is to step up patients, because many patients, particularly those who are frail, could be treated at home or in a care home rather than being admitted. So the idea is to treat them there. At the moment, the virtual ward is in its infancy. Over the past 12 months, we admitted just under 1,500 patients, saving length of stay in the hospital of just over 7,000 days. And that gives you a a net saving to the system of £2.4 million, but it's not about money. It's about quality of care, by getting people home quicker and making sure that they enjoy being home quicker, and they do usually. The GPs appreciate it, the patients appreciate it, and our colleagues appreciate it. And with that, I'll stop talking.
I should say Robert is a fantastic frailty consultant. He's part of our team. We're Sutton Health and Care, but Robert will come out. And again, this model is very, very unique, and I can't stop him talking. So I did say I'd be creeping up on him. Sarah, just stop. Sarah's going to just give you a very, very high level of data, just to give you some examples here.
So the capacity for our virtual ward is 100 patients.
Is that? Yeah, that's it.
Yep, is 100 patients. To be honest, we're not there yet, but we're getting there. As you can see from the data on the left of the screen, we have got issues. I'll be perfectly honest, with referrals from the hospital. And I think it's gaining trust. The hospital gaining trust in our virtual ward, to know that the patient is safe, is well looked after. So we're working really hard on that, and we do have 2 in-reach virtual ward clinicians who go to the wards, they talk to the staff, they'll talk to the patients, and we're starting to learn that actually by giving feedback to the medical team to say, actually, this patient that we took was absolutely fine, they were really safe, and we've now they've become well, and we've passed them back to the GP. So it is gaining trust. As Robert has alluded to, Robert and I are going to try and work really hard with our care homes in Sutton, because it seems that their length of stay in hospital is far longer. As Robert has said, 22 days. So over the next coming weeks, Robert and I are going to be working really hard with the care home support team. I've alluded to, as you can see, the majority of our patients are over the age of 85, and most of those are female. We have, to begin with, the length of stay on the virtual ward was rather lengthy, but we've now reduced that, and the majority of patients are on the ward for 10 days and then are passed back to their GP. As you can see, the next slide shows the number of patients that have been admitted per PCN. And this shows, as Robert has said, that our virtual ward admissions over the last year have been 1,435. And the visits that the clinicians have done to these patients over the year have been 5,740. With the remote monitoring, I'll quickly go on to that. We want, so as it says, 50% have been suitable for remote monitoring, but we've only managed to get 25% onto remote monitoring. And again, that boils down to the fact of the cohort of patients. They are elderly, it's technology, and they struggle with the technology. And that is it from me.
So, that gives you a very whistle-stop of the virtual ward. The last slide, again, difficult to read, but please do have a look at it. It's what we feel are the success factors. So you'll see we've got a lot about improved patient satisfaction, reduction in hospital complications because people are being discharged early, and therefore, as well as that, a reduction in hospital deconditioning, which is really, really important. We've given you length of stay, reduced length of stay, so therefore there's a cost impact. And obviously a improved communication and network with the hospital clinicians, with our frailty consultants, and with our community and our GPs. And as I said, we are so, so proud of this model, because actually we think we are we have the best model across Southwest London, but as I said, our selling factor is very much that we have 100% GP engagement in this. which is really powerful. Going to click you onto the story now, because again, you'll see professionals and patients talking about the virtual ward. Thank you. Just bear with Sarah while she does that. This was a video that we took for our HSJ award. We didn't get the first prize, but we were one of the runners-up. And that was last year.
Skip the ad.
Skip it.
Patients spend many, many days in the ward, but now we can safely and efficiently discharge patients into the community where they receive the last 3 to 4 days of their treatment in the community. They prefer it, the families prefer it, and we know that it's safe.
So we can look at everything just to make sure they're on the correct dose, there's any drug interactions. Actually, sometimes medications have been started but they haven't been reviewed and maybe they don't need to be on it. So it's actually important to stop medications just as it is important to start. So we do have a really good clean-up of their medications and go through and see what they need.
For the virtual ward, for me personally, I feel a lot more confident when managing people who are discharged from cancer. A little earlier than they would otherwise might be. Patients are happier to be in their own home. They're less fearful. I have a lady in her late 60s who is absolutely worried about going to hospital, but we're able to keep her at home with her family looking in on her, and I'm a lot more confident that she's staying at home and getting medical advice, and I'm getting advice from the specialists at the same time, and it's working really, really well.
I was feeling quite ill, and I went to the doctor's surgery, and he told me I had shingles. I didn't realise just how bad one can feel with something so simple. But the nurse in the virtual ward came in every day. It's kept me indoors, able to cope and nursed me back to health.
And that's it. So very happy to take questions or whatever.
Thank you very much indeed, all three of you. You really brought it to life, I think, for us, despite the technology. Apologies. Do not apologise for the technology. So, any questions from colleagues? Andrew.
Yeah, thank you. Looks and sounds brilliant, and most importantly, I'm sure it's the best thing for patients. So it's really impressive. Two things that questions that emerged for me. One was your engagement with general practice and the fact that you've got 100% buy-in from PCNs and practice. That's quite impressive, and I wonder how you did that, and was there a resource implication with doing that? And the second question was just around responsibility. So you're getting the GPs to take responsibility for the patients, whether it's avoiding admission or an early discharge, and I wonder how that's working, and clarity around responsibility when you've got people discharged, particularly if they're more complex. That strikes me as a challenging thing to work through. I just think there's some really good learning from here, particularly for St George's and the work that's being done there around virtual ward.
I mean, I can't say that was all easy at the beginning. So, as I said, this is now two and a half years in development, and the first 6 months with full GP engagement, was quite difficult. So we probably got about 30-40% buy-in, and the others were like, oh, don't really want to go there, don't really want to do this. There is a DES behind so directly enhanced service, which is so money from primary care, not from us, that the GPs get to participate in the virtual ward. However, I think what we found is people buy into it, so they come to the first MDT and they're structured. So they come for Mrs. Brown at 1 o'clock, they come for Mr. Smith at 1:10. So they don't have to stay for the entire time. I think over the last year, people have gone, oh, actually, this is quite good. Actually, I quite like this, because you've got frailty consultants, you've got nurses who deliver care, you've got pharmacists. So I think now, over time, it's really, really well received, but it's taken time and effort and goodwill. So I think that was the answer to your question. Was there another one on that?
I asked specifically about responsibility, but that's a complex one, so I don't expect you to cover that.
Maybe I could answer that.
Yeah.
So, yesterday afternoon in the same venue, I did a teaching session for registrars going into general practice. And their tutor made the following comment. And he said that the amazing thing about the virtual ward is that it provided continuity between the hospital and GP land. So before, even though hospitals send discharge summaries, okay, the GPs either read them or didn't read them. Okay, so there was always a gap in continuity of care. Now what happens is GPs are told in advance when the patient will be discussed. They're given 10-minute slots. At the virtual ward round, the GP is sitting with EMIS and his information. I'm sitting with the hospital system here, and we're discussing the patient. There's continuity of care, and therefore the GP feels much safer. Even with complex patients, the GP feels a lot safer. In terms of medical legal responsibility, it's a given that when patients leave this hospital, the hospital consultant isn't responsible for the GPEs. But this way, it's the ease of the patient in the community. At the same time, any therapy that's provided that's not standard practice in general practice, the medical responsibility lies still with the hospital. For example, IV antibiotics.
Thank you, Robert. So I've got two other hands I've seen, and then we're probably going to have to leave it there, sadly, because of time constraints. So Kate and then Derek. So we'll take the questions and then we'll take the answers. That's all right. Kate.
My thing's died, I think. I'll try and speak really loud. But firstly, that was amazing. Thank you so much. And you answered all the questions I had. But one thing and I think we are in the foothills at St George's, that we do not have an equivalent service, I have to say. Thursday night talk about, Thursday's helping to get there. And I wish we could have your service. But one thing I noticed that you do, which I'm sure has really helped, is have your clinicians coming in and working with the hospital clinicians, because there is a real thing about risk taking, isn't there, and trust, and learning, the learning loop about, and it's lovely hearing that lady talking about her experience not having to come into hospital at all, which of course is the preference for everybody really. So interested to know if that's made a bit of a difference to people being referred into your service.
I'd love to say we were. Oh, sorry.
Let me take Derek, because we're so short on time, and then you can respond to.
Yeah, very quickly.
Yeah, thanks. Just to know, I think this is fantastic. That's the first thing I wanted to say, and a great model. I remember one of the other things you do at board, at the beginning of board, is we go to visit places in the hospital. And I remember about 2 or 3 months ago going to visit a ward, I think, was it Buttercup Ward? Something like that, maybe I've got the name wrong, which was a ward run by GPs.
Richard Black.
Lavender.
Yeah.
That was botanic. Sorry, I'm trying to keep that. Lavender botanic. Anyway, and that was a ward run by GPs, a short-term ward, I understand. But I think that was also a fantastic model to do exactly what you're talking about, which is bridging. How did that fit in with this model, or is that something completely different?
So
you might want to
yeah.
Kate's question as well. Sorry, two questions, but I thought that was a great bridging exercise as well.
So that worked really well. We actually provided the therapy on that ward. So, and we again had our InReach virtual ward clinicians coming in pulling out. And because we work very closely with the PCNs and actually work with the staff from that ward, actually it really helped. So, and we would hope to continue that. I don't think we're there. As Sarah alluded to, we have made some steps. And one of the reasons we put in reach clinicians was because we weren't being able to pull out patients quick enough. I don't have the magic answer. I wish I did. It's, as Sarah said, it's building trust. It's going to ward rounds, board rounds, getting in there. Robert and his team try their best, but we're not quite there yet. And as I said, this is where we want to sort of try other innovative solutions. But we've got further than we did, but we're not there.
When Sarah and her colleague came to see me, sorry, this has given up the ghost completely, hasn't it? The thing that struck me most was that it could have been exploited more, and it is related to that point, I think, about people in the hospital having confidence to hand patients over, as it were. So it's clearly work in progress, but a great story. I might have to give James the honours.
So I agree with everything that's being said. I think there's probably a couple of things just to come in on. I think the first is, I completely agree that there is more work to do in terms of the risk threshold and trying to get people out earlier. I think that as we go further and further into that, we get into people with higher levels of care dependency as well. So the link into social care and reablement becomes, in a sense, a potential constraint, although I don't think it's an insurmountable one. I just think it's another level of coordination. We did also notice that when we had duly adopted industrial action, we saw some slightly different patterns of admission into the virtual ward, I think, as well. And I think there is definitely something that links into Robert's point about training. So we need to make sure, these models are going to be part of clinical practice everywhere going forward. So one of the things that we need to think about as a postgraduate training provider is how we are training the clinicians of the future, not just doctors, but all clinicians, to use these models effectively. Because they are the future consultants, and they are the people that will drive the transformation. On Lavender Lodge, it was a short-term scheme, and we're not able to continue with it, but we are hopeful that we will be able to confirm national funding for a model that builds on the best of it, and that we will have from later on this year.
Thank you very much indeed, James. I'm sorry, we've just scraped the surface, really, haven't we? And I was reflecting that maybe we should have had you come and speak to a board development day when we could have spent a bit more time on this. But I hope it's given colleagues a sense of the great work that you do and the potential to do more, and for Georges to learn from it. So, did you want to say something finally, any one of the three of you?
Just thank you. Thank you.
No, I think the thanks are all the other way. Thank you very much indeed. Thank you all for coming, because you all helped, I think, really illustrate what a difference it's making.
Please do make sure that you get the slides, though, because then you can have a look at those in detail.
That's great. Thank you, Lucy.
Thank you.
Right, that is the end of our meeting. I just want to check. We've had no written questions, but George's governors are always able to ask questions without submitting them in writing. Did you have anything you wanted to flag up, Richard?
I don't think so. I think it was time to
Well, hopefully if there is anything, you have an opportunity over lunch or something. So, okay, guys, it's lunchtime. So we're going to start again at 1:30. I think people need a little break. And if other people don't, I do. So, thank you.
Good. Well, you're taking a lot of notes.